Good morning. I came out a little bit more.
Oh, no.
Catherine, you got on.
I know, I'm so excited. I made sure that I was here in plenty of time to get this thing. I was determined.
You did. Hello. Hey. Oh, okay.
This is ridiculous. I'm
Okay,
bound to
because
be
I
able
can
to.
hear you guys just wanted to see you guys. I had to turn it off and then see if that helped. Okay. All right. All right. Just text me if that's happening.
Okay.
All right. I'm hanging up. Can you hear me?
I can hear you, but you're kind of breaking up.
Yeah, we can hear you now.
Angela? Okay. Is that any better?
Yes.
Yes.
Not better. Okay. Good. I think there might be a little bit of a time delay.
I'm just sending Will a message. I hope so. Not yet.
Can you guys see me at all? Because I have suddenly lost the screen.
No.
I'm going to get out and get back. All right. I'm going to get out and get back in.
Okay.
How about that? Can you see me now?
No.
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 Check your video at the bottom.
Yeah, my video is on and I can see all of you and I
How about now?
Now we see you.
Okay. Hear me.
Yes.
Good morning, everybody. My name is Alex Jansen, and I'm staff to the Board of Health. As you may see on the screen, we will allow a 5-minute log-on period for all participants to join the meeting and get settled. Please remain in the meeting, and we'll get started at 9:05. Thank you.
Thanks, Alex.
I can only see some of you. Faye, I can see you.
That's good.
I can't see Mary Margaret. I did earlier, but I can't see her.
Alex, will you let me know when we can start?
Madam Chair, we have almost everyone here. We're missing a few board members, but we are good to get started when you would like to.
Okay,
If
let's
you wanna
just
them
give
a
it
few
one.
more-
Yeah, let's just give it one more minute and then we'll start.
Absolutely.
All right, let's get this started. Good morning. I call to order the March 18th March 18th meeting of the Virginia State Board of Health. This meeting is being conducted in a completely virtual environment and is being recorded. There's several things that we'd like to review before we get started. First, the names of all the board members, along with the constituency that they represent, are displayed on the screen. And in addition, there are several staff members of Virginia Department of Health and the Office of the Attorney General who have physically assembled at the Madison Building in Richmond for this meeting to comply with the governor's orders on social distancing and masks to limit the spread of COVID-19. They will be wearing face coverings and sitting 6 feet apart. The list of all the staff members participating in this meeting is displayed on the screen. Several of these staff members are participating virtually. Lastly, all votes that are taken by the board during today's meeting will be roll call votes. I will be restating the names of the members who make motions or seconds. And attendees, you will not be able to unmute yourself. When we get to the public comment period, you will be unmuted by the host if you have signed up to speak. And with that being said, Ms. Jansen, could you please call the roll?
Mr. Kreitzer? Mr. Kreitzer? I see him. All right. Mr. East?
Here.
Thank you. Mr. Edmondson? Mr. Edmondson?
Here.
Thank you. Ms. Hines?
Here.
Thank you. Ms. Harrison?
Here.
Thank you. Dr. Jang?
Here.
Thank you. Dr. Kinzer?
Here.
Thank you. Dr. Klein?
Here.
Thank you. Dr. Miller?
Dr.
Ms.
Miller is
Pritchard?
not here today. Here.
Thank you.
This
Dr.
is
Pierce?
Gary, I'm on, I'm sorry.
Thank you. Dr. Pierce?
Here.
Thank you. Dr. Schuler? Okay. Dr. Schwartz? Here. Thank you. Ms. Waddell?
Here.
Thank you. Ms. Whipple?
Here.
Thank you. Madam Chair, we have a quorum.
Thank you very much. If there are no questions, Ms. Jansen will now review the agenda for today's meeting. I know that there are lots of questions about COVID-19 and our COVID-19 process, and I just want to let all the members know that we will include all of your comments and opportunities to talk about that during or immediately following Dr. Oliver's update this morning. So, Ms. Jansen, if you could review the agenda.
Absolutely. So we will begin with the approval of the December 3rd, 2020 minutes. We will then have the commissioner's report by Dr. Oliver and other staff to assist. We will then take a short break, followed by a review of the regulatory action update and matrix, and then have a public comment period for those that have signed up, followed by another brief break. And then we will have the presentation of the fast track amendments for the Virginia Medical Care Facilities Certificate of Public Need Rules and Regulations by Rebecca Allen with the Office of Licensure and Certification. We will then have a presentation for the legislative update from the 2021 General Assembly session from Mr. Hilbert, followed by the budget update from the 2021 General Assembly session by Ms. Stephanie Gilliam. And then we will have the appointment of a nominating committee by you, Madam Chair, followed by any other business the board wishes to discuss, and then adjourn.
Thank you very much. All right. All righty, the next item on our agenda then is the approval of the December 3rd, 2020 minutes. Can we get a motion to approve those on the floor?
Madam President, I so move.
Is that you, Ms. Whipple? Sorry.
Yes.
Okay. Do we have a second?
Sorry. Supposed to
Linda
say
Hines.
Reed, I guess.
We have a motion from Mary Margaret Whipple and a second from Linda Hines. Is there any discussion? All right, and then Ms. Jansen, could you call the roll vote?
Mr. Kreitzer? Mr. Kreitzer? I can come back. Mr. East?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller is not here. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler? Join. Okay. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple?
Yes.
Thank you. Mr. Kreitzer?
Yes.
Thank you. Madam Chair, the vote was 13 ayes and 0 against.
All right, thank you very much. The next item on our agenda is Dr. Oliver's report and COVID-19 update. And I'm just going to ask that we let Dr. Oliver get through his entire report unless there are questions that are germane to the report. And then we will have all the time we need for discussion and questions immediately following, unless there are any problems with that. And if there are, you'll have to speak up because I can't see you. Dr. Oliver.
Good morning, Madam Chair and members of the board. Can you hear me okay?
Yes.
Oh, wonderful. Well, I really appreciate this opportunity to update everyone on Virginia's response to the COVID-19 pandemic. Go to the next slide, please. And you'll see here the outline for what we'll be going through regarding the current disease burden and transmission, some new ideas around testing and containment, what's going on in long-term care facilities, our plans around community mitigation, communications, and then we'll talk about the vaccination campaign and funding allocations that we've been able to utilize in our pandemic response. Dr. Danny Avula is here with us today. He is the state coordinator for our vaccination campaign. I will actually have him present that portion of the report to the board. Next slide. This is a epi curve of the cases by date of onset. And it just shows what we've been through over the last year. You will note that we had our first case in March 7th. The case counts began to climb from there, as they did around the world. And on April 1st, that was when the governor issued his stay-at-home order. Cases continued to rise, and other measures had to be talked about in terms of the mask order, asking people to maintain physical distance, and so on. In mid-May, we began our Forward Virginia campaign to slowly, based on guidelines, loosen restrictions. And around the end of May, around Memorial Day, began opening up. And you know that in that summer, when we saw a new surge of cases. The initial surge of cases was really focused around and concentrated in Northern Virginia. The case surge in the summer was in our eastern region, and we had to institute restrictions and enforcement measures for the eastern regions, and that subsided there, only for us to see a surge of cases in far southwest Virginia right after that. And then, of course, we went through what we went through following the fall and winter holiday season, when we believe there was a lot more social gathering, and that resulted in a big spike, 4 times as high the incidence that we were experiencing last spring in cases across the Commonwealth. That peaked in mid-January, and we've had a decline since then, but we are averaging around 1,300 or so cases a day, which is as high as that what we experienced in April, May of last year. So there's still lots of COVID-19 out there. The virus is spreading widely in communities across the Commonwealth, and for that reason, we're not out of the woods. Next slide. As you're all aware, COVID-19 has disproportionately affected African American and Latinx communities. This is a graph depicting deaths per 100,000 population, and you'll see that for African Americans, they experienced a death rate significantly higher than that of whites, and the Latinx community was hit even harder than that. Hospitalization rates were higher in those populations as well, about 2 times higher for blacks and almost 3 times higher for whites. This is an issue that has meant a lot in terms of what we need to do in our focus on vaccination, but we'll talk about that in a little bit. Next slide. Testing across the Commonwealth has, as you are all aware, got off to a slow start for a number of reasons. One, of course, was the scarcity of testing kits in the initial stages of the pandemic. Or not just kits, but then different elements within kits, from swabs to viral media for sending the samples and other things. And we were also slow to mobilize the National Guard to help out on the testing. But once we did that, things really took off. We had a goal of getting to I think it was like 15,000 tests a day, and then we were able to manage to do that, and it's been averaging much higher than that ever since. That is predominantly done by the commercial sector now, and that's a good thing, and that's reflected in their percent test positivity, which is down close to 5% these days, indicating that we're adequately testing. We decreased the number of community testing events that were being done by local health departments, and as that decrease happened, that was done because more and more testing was being done in the commercial sector, which we can see on the next slide. So on the left there, you can see how towards the end of the year, we decreased our community testing events pretty dramatically, but testing locations in other venues, particularly the commercial labs and so on, increase, and as a result, we've maintained adequate testing. Next slide, please. Another important aspect of that has been the availability of testing across the Commonwealth. There's no region in the Commonwealth where someone can't find testing relatively closely to wherever they live or work. Next slide. Here is just some points regarding what we want to ensure about testing going forward, that we want to provide equitable access to testing. So we'll be monitoring the availability of testing across the Commonwealth and looking to add additional staff at local level whenever necessary, in case we do need to do community testing events for outbreaks or as the schools open and so on. We have the availability of antigen tests, the rapid testing for COVID-19, and FDA is it has some favorable things to say about a couple of the at-home tests that are being looked at, and they may become available soon. And we are also currently looking at possibility of making screening testing available to the pre-K to 12 schools. We will be establishing specialized teams that will look at, that will combine testing, containment, and mitigation strategies as part of our containment of the virus and its spread, and really want to have those teams focus in on schools and congregate settings. The testing navigators will be also serving as case managers, connecting individuals from organizations with testing in the community. And we'll be doing this also on a regional basis with regional testing coordinators. Next slide, please. Our containment efforts have had a big impact. We recruited and maintained a very adequate workforce. You will recall that last year we went on a campaign to increase our workforce by about a third, recruiting and training and deploying about 1,200 case investigators and case and contact tracers. We now have about 960 of these folks, and we have a number of them with other language skills other than English, including a number of Spanish speakers, as you can see there, and have done a very intentional effort at trying to increase the numbers of African Americans who are case investigators and contact tracers, as well as those who are Latinx. You can see the number of cases that were contacted there, about 61%, and we were able to complete case interviews on about 48%. And you can also see the number who were contacted within 24 hours of their case being reported, a number which we would like to, if possible, increase. And then the number of contacts that we actually interviewed. One of the things that was noteworthy in our work around contact tracing was what we did in terms of digital innovation. We were the first state to adopt exposure notification technology with the advent of COVIDWise. This tool has been downloaded by close to 2 million users in the Commonwealth. And through it, some 3,000 positive reports of COVID-19 have been reported. Next slide, please. The guiding principle for our containment work continues to be boxing in the virus and its spread, which deals initially with the testing, which I just went over, and identifying cases, and then isolating those cases, finding out who their contacts were, who they may have exposed to the virus, and then quarantining those people and in that way boxing in the virus. But this is an adaptive model. It's adaptive because it will depend on the spread of the virus at any particular moment in time, and as the case incidence increases, like it did, say, December and January, though when you have that many cases happening, we were upwards of, on some days, 9,000 new cases. When you have that many cases, it's really not possible to track down all of the contacts of those cases. And you want to focus really your attention on the cases and have the cases themselves follow up with their contacts. We do shorter interviews. We also had to pull in support from regional team support for the local teams. In a period where you're seeing a decline in the incidence of cases like we're having now, you can have more time available to the teams to do the case investigation and follow up and trace all the contacts, and so it's going to ebb and flow depending on the actual case incidence and transmission of the virus in the community. Next slide. So I talked about that box it in strategy, and our containment now is building on that and moving into a different phase, and our EPI team is thinking of this as containment 2.0. And this slide summarizes what we plan on doing in this new phase of our containment efforts. There'll be specialized positions that will really be integral parts of the community to increase the ability to really do surveillance and look for outbreaks and responding to those outbreaks, primarily looking at workforce skills to improve those workforce skills and backfill as needed. As I mentioned previously, we'll be developing specialized teams to deal with schools and congregate settings, as well as some industrial or business settings. We'll be sending program managers to the districts to help out on this, and we'll be expanding our ability to tweak our hiring process to fill these specialized positions. We're going to be strengthening social support as well. Both, it's needed for a number of reasons. To put someone in isolation or quarantine and have the ability to stay there for the entire length of time, they often need social support. We have care resource coordinators in the districts who will be able to help with that, and a testing navigator to connect clients to testing resources. But we also now have an added resource, which is Unite Virginia. This is a cloud-based network that pulls together all the various social services that someone may need, and links it in a way that it can be accessed from any place within the Commonwealth, and from one social service to another. Someone shows up at a food bank, but they also need help on housing. The person working with them at the food bank can connect them with the needed resource on the housing issue. Or they show up in an emergency department, they can be connected to medical legal services, or to someone to help them with their issues around food insecurity. So that'll be a valuable addition to what we're able to do around supporting people who are in isolation and quarantine. But it's also important for those who have suffered the social and economic impacts of COVID-19, and therefore will be important after the pandemic in terms of recovery from those impacts. We will improve some efficiencies with technology. We're in the process of obtaining a case management tool, which will increase our ability to really track cases and assign them to our teams. Looking for ways of improving our ability to reach out to contacts over the phone with caller ID for better response. COVID-wise will continue to be a very important tool, and we'll look at ways of both expanding its uptake across the Commonwealth and ways of supporting its capabilities to identify people who may have been exposed. We are also working diligently to improve broadband access across the Commonwealth for our local health departments. Next slide. As you all are well aware, long-term care facilities really had just an incredible impact of COVID-19. As of March 15th of this year, outbreaks in these long-term care facilities represent 35% of all the outbreaks in Virginia to date. Most of those, as you can see from this slide, occurred during the peaks of the surges that we experienced, and that's because what happens with any of these outbreaks, really in congregate settings or the schools for that matter, it's community spread and widespread community spread of the virus that leads to these outbreaks by employees and other visitation and so on, bringing the virus into that congregate setting. So in the spring of last year, when we saw the surge that was really centered up in Nova, most of the outbreaks in the long-term care facilities were also in Nova. And then when we saw it in Eastern region, most of the outbreaks in the long-term care facilities was there in the Eastern region. Likewise, when we saw the big surge in Southwest Virginia. Now, although there are still some outbreaks in the long-term care facilities, the decline in the case counts is a huge improvement. We've really dropped from that peak back in December. There's also been a lot of developments in the long-term care facilities themselves. There's been a lot of learning about infection control and how to do that more appropriately. They've improved their testing capacity, both from support from the federal government, but also our Virginia Emergency Support Team and the health department has provided lots of antigen testing with the BD Veritor testing kit to all of the skilled nursing facilities. So through these ways, there's been a real improvement in the ability of the administration and staff of the long-term care facilities to deal with cases of COVID-19 that do appear, isolating them and preventing outbreaks from occurring and keeping the case count down. Next slide. This slide just underscores what I was telling you about in terms of how the outbreaks in the nursing homes reflect where the surge in cases were occurring. So you can take a look at that at your leisure. Next slide, please. In addition to the improvements in infection prevention and control in the nursing homes, and the work that's been done with the support of VDH to do that, and also with the support of colleagues from Department of Social Services and Department of Behavioral Health. There's been, of course, the advent of the vaccine, and we were able to vaccinate a significant number of the residents in long-term facilities, as you see here. As of March 15th, nearly 309,000 residents and staff in long-term care facilities in the Commonwealth have been vaccinated. We continue to work on that because of the turnover in nursing facilities and assisted living facilities. I think it's somewhere around 7,500 a month. So we have to continue to do vaccination there. But the extent of the vaccination is such that CDC and CMS have changed their guidance regarding indoor visitation, and we will be adjusting our guidance around that in accordance with those changes. We mentioned here on this slide the BRIDGE program, which has been established to meet these ongoing vaccination needs to deal with the turnover in these facilities, and working with a number of pharmacy partners also to maintain the vaccination of those facilities. Next slide, please. We have worked very closely with the Department of Education around providing interim guidance on K through 12 school reopening. The stance has been to try to provide guidance for helping local boards look to ways that they can safely reopen. Looking at how community spread conditions that ability, and then the need to accordingly plan mitigation measures within the schools to deal with that, and their ability to do those mitigation strategies being one of the key things you should consider in whether or not and how you should strive to have in-person instruction. So we've updated that. We've updated the indicators, the dashboards that we have around that as well, to reflect the changes in the quantitative indicators. Next slide. In this, here you can see these revised school indicators dashboard. We've been also really trying to provide technical assistance for the school divisions and local officials to discuss data that they need to assess, and trying to think through the type of in-person instruction they want to have, and what sorts of mitigation strategies they need to implement. Next slide, please. We were charged by the Executive Order 72 to enforce the executive orders around mask wearing, social distancing, and restaurants in particular. And we've had to deal with lots of complaints through our online reporting tool, and had to respond to a lot of these reports. A lot of these reports were responded to by VDEX, who partnered with us on this, as did the ABC, which and some local um, law enforcement, public safety officials as well. Next slide. We have mounted quite a large communications effort around the vaccine, explaining the safety of all three vaccines, explaining their effectiveness. Dr. Klein, thank you for all the work that you did with the advisory work group for the VEST and organizing a number of those community educational events and education of clinicians and other providers. We've done op-eds, we've done satellite media tours where we spend many hours doing multiple interviews, like do 32 interviews across the Commonwealth in one session. We've done town halls and establish a communications hub, which is a way for our public information officers around the state to have access to tools that they can use in their local areas and have the same sort of message going out in a consistent way. We've had medical experts participate in a number of panels and on webinars and other types of events. Partners that we have in the community, such as Dr. Wen, who's the director of the Massey Cancer Center. He runs a group called Faith and Fact Fridays, where he brings in faith leaders, primarily from the Richmond area, but it can be upwards of like 400 pastors and ministers. We utilized one of those when he was able to get Dr. Fauci to come and speak, and we got 5,000 people on the Zoom for that, and about another 5,000 were checking it on the Facebook streaming. So those efforts have continued with the Joint Information Center, which is the arm of the Virginia Emergency Support Team that is handling our communications. It's up and running and now continuing that communications effort. The next section, what we're going to talk about is our vaccination campaign, and I'd like to hand it over to Dr. Avula, who you all know. He was the director and is the director of our Richmond City Health Department and Henrico County Health Department, and was tapped by Governor Northam to be the vaccine coordinator for the state. And I'll invite Danny to talk about the vaccine campaign.
Thank you, Commissioner Oliver, and good morning, everybody. It has been a fast and furious couple of months as this vaccination campaign has gotten underway, and I can't say enough good things about our incredible colleagues, both at central office within VDH and out in the districts. I mean, what has been going on is, everything you just heard Norm talk about has been really primarily driven by VDH staff over the last year. And at each turn, there's just another massive weight to carry, but VDH has been resilient and forward thinking, and really, I mean, just the last 2 months have been amazing to watch. So this slide is just a couple of days old. We had to obviously turn the slides in, but if you look at the data, this dashboard is updated every single morning. So this morning, we're almost 2.9 million doses. We're about 22% of Virginia that has received at least one dose. And we reached the important milestone this week of having 1 million Virginians fully protected. And so things really are picking up pace. We have really, focused on our efficiency, our ability to make sure that we're getting out as much vaccine as possible, to make sure we have as much capacity built as possible, so that really the only thing slowing us up is the influx of vaccine. And by that metric, by the doses administered versus the doses we've been distributed, we have ranked pretty consistently in the top 10 in the country over the last month. Both the New York Times and Becker's Hospital Review do a daily update. And so we were at some point fourth in the country this past week, and that fluctuates a little bit every day. But we also, next slide, we also started this campaign with the governor saying that we needed to get to 50,000 doses a day to vaccinate Virginia by the summer. And what you'll see here, and this again is a couple days old, we were averaging about 53,000 doses a day. That number has dropped a little if you look today, but really just because of kind of the weekend blip. I fully expect this number to be up in the mid to upper 50s, if not the lower 60s, as the data catches up and we get through this week. But all that to say that we are at and above the target goal of getting to that 50,000 doses a day. In fact, you'll see multiple days on here where we have exceeded 70,000 doses a day. And we're finally at a point where the vaccination supply is catching up. And so what that means is that, for all of the folks who have been in, you can go to the next slide, and the next slide really shows us how that has been distributed out. You'll see that local health departments have done the vast majority of our vaccination, along with our hospital and health system partners. And then increasingly, we're seeing more and more vaccine coming through private medical practices, through pharmacies, and through other community health providers, entities like the Department of Corrections or the DBHDS to the group homes. So you can kind of see the spread there of of how the distribution has looked. And more and more capacity is coming. And so we are maximizing the channels through which we're delivering vaccine. Next slide. So you'll see here that one of the channels we're maximizing is the pharmacies, and the feds have really designated pharmacies smartly as a way to get vaccine out, both because pharmacies do a lot of vaccination in general, but also because they have really wide-ranging footprints. There's a lot of brick and mortar pharmacies all over the state, so it's a great way to get coverage. And so what you'll see here is the breakdown of how those federal pharmacy partnerships have worked out with the different entities. We've just brought on a couple more in Wegmans and Harris Teeter in the last couple of days. CVS is so much outpacing the rest because CVS did the bulk of the early pharmacy work. If you'll remember, in phase 1A, which was our healthcare workers and our residents and staff of long-term care facilities, our nursing homes and assisted living, CVS did the bulk of those vaccinations in 1A and received much of that vaccine early on. Next slide. So I mentioned briefly the 1A. Right now, we're in 1B as a state. And so as you see here, just a screen grab from our website, which is updated on a regular basis. But the vast majority of the state, we've all been in 1B. Just this week, we announced that a couple of districts have moved to 1C. So a quick recap, 1B constitutes individuals who are 65 and up, people who are 16 to 64 with underlying conditions, and then a host of frontline essential worker groups, folks like policemen and firemen, teachers, childcare workers, grocery store workers, et cetera. What we've seen in some communities, and particularly in rural communities that just have a lower population density and have been able to move through the demand in their community faster, is that they're ready now to go into 1C. And I anticipate this will be the case for most of the state, probably in the next 2 to 3 weeks. I really think that the entire state will get through their eligible 1B population by the second week of April. We'll then progress into 1C. And as I said, 2 districts have already done that. 1C is kind of the next tier of essential workers, so folks who work in public utilities, public works, transportation and logistics, legal, finance, so a few other categories there. And that's a pretty small number. I mean, statewide, that's 600 to 700,000 people. So I expect that we will move through 1C very quickly in a week and maybe 2 weeks up in Northern Virginia and the Richmond area, more populous areas of the state. But all of that to say, we will be open up to the general public by the end of April. I think we will beat that presidential goal of May 1st by a week or so. So very exciting things. I think if anybody, hopefully for you all, as you talk to friends, family, colleagues, or even for yourselves, have felt that tangible difference in terms of how things are going, the people you know who are able to get vaccinated. I think certainly my inbox has felt very different from the beginning of January to now. Just, the shift of people really frustrated and full of anxiety about how they're going to get vaccinated to an inbox full of thank yous saying, if one other thing I'll say about that, if any of you have the chance to actually go to one of the mass vaccination sites, they are remarkable. I was at it about 2 weeks ago. It's been a super intense couple of months. And I think Secretary Kerry could see sort of the weariness on me. And he said, Danny, you should just go to one of the sites. So I went to Arthur Ashe. And just like the feel, the morale, the energy in those sites was incredibly uplifting. And so I think for any of you to just go and see it in action, I think would do the same, just to see the gratitude of people who are getting vaccinated, the efficiency of the operation. The New York Times actually covered the Richmond site last week. And anyway, there's so many good things happening around the state. I'd love for you all to see it firsthand. Next slide. I talked about this. Maybe a couple things here that on the slide, big improvements and process improvements over the course of February. We started a lot of the vaccination in the hospitals, and local health departments were doing small amounts and kind of had their localized registration processes. As we were moving to 1B and the supply demand curve really shifted, we recognized the need for a centralized process. And so we rolled out vaccinate.virginia.gov. It's a very clean way to go in anywhere in the state to register or to get yourself on a wait list for a vaccine. And that list is what we're using. We're pulling and curating different names from those lists by locality to populate the appointments for each clinic that we're running. So for example, in Virginia Beach, if we're doing a 2,000 person clinic for 65 and up, we would just pull all of the data from the vaccinate.virginia.gov wait list for residents of Virginia Beach who qualify as 65 and up and populate those appointments accordingly. We also recognize there's a lot of populations that may not be tech savvy or have reliable internet access or speak English or feel comfortable registering through a website. And so we all at the same time rolled out the state call center, 1-877-VACCINE-VA. We have about 10% of our agents that are Spanish speaking, and then the option to call back in 100 different languages. And so we really are trying to create access to every demographic across the state to be able to get in line for a vaccine. And the system has been working really well. We've been populating more and more of our appointments through this over the last month. Next slide. So here are just some of the metrics on how much use the pre-registration system has gotten. You'll see almost 10 million page views and over 1.1 million people who have registered. You can sort of delve into the details on that later. Next slide. Similarly, for the call center, we've seen over 300,000 calls handled to date. On average, somewhere that's probably maybe 7,000 to 10,000 calls a day, something like that. We get an update from the call center like this every single day. So I've been really pleased with the progress that they've made. Next slide. So what are some of the equity considerations here? We have known from this past year that COVID impacts different populations differently. We know that African-American and Latino residents have much higher rates of hospitalization and death. In part, that's because of the roles they play in our society, the frontline essential worker roles, the reliance on public transportation, the rate at which they live in multi-generational housing, the way that they are just really at higher rates of exposure to contract COVID. But then we also know, because of underlying and systemic issues around the social determinants, around healthcare access, that they have higher rates of underlying conditions, which put them at higher risk for hospitalization and death. And so we've been incredibly focused on and thoughtful about how we reach these subsets of our population. throughout our vaccination campaign. Many districts have mobile capabilities and have gone into public housing or gone into neighborhoods to do vaccination sites. There have been a number of partnerships with the NAACP or with African American churches to do vaccination events. And then we've really built the equity lens into the way that we think about how we allocate vaccine, but also how we allocate resources like our mass vaccination centers. And so some of the methodology we applied in deciding what sites should be prioritized really looked back on the percentage of population who are Black and Latino, the percentage of, or the impact of COVID in those communities based on hospitalization and death rates. And then also looking at 65 and up, because we know that that is another really, probably the most significant risk factor for poor COVID outcomes. And so when you look at the list of the places this week, it was Danville, Portsmouth, and Petersburg, clearly a prioritization based on the racial demographics and access to vaccine in those communities. And that kind of lens, along with our weekly evolution of how we're allocating vaccine around the state, there's a continual focus on how are we maximizing access for those communities. Additionally, there was legislation just signed that requires the provider who's collecting data to include race and ethnicity data. We still have a gap in terms of early on, there were a number of entries where we didn't capture those fields. And so now that is required for all providers. Commissioner Oliver has been very insistent about this in commissioner letters to providers every month or so. And so we are seeing that number in terms of the relative percentage of fields we don't have starting to decrease. Next slide. So I mentioned briefly the community vaccination centers in Portsmouth, Danville, and Petersburg. So these are federally funded, FEMA funded, but state managed sites. That the intent is really to help with the surge. We know that as we head into April and get through May, opening up and completing the general population, we need more urgent capacity to do large scale vaccination. In the long term, I think we've got plenty of capacity through our health departments, hospitals, pharmacies, and providers to do the long-term sustained work of COVID vaccination and all kinds of vaccination looking forward. But as we scale up for 70 to 80,000 doses a day in April and May, we really do need this additional surge capacity and have the federal funding to make it happen. And so we have outlined those 3 sites that started this week. We will be in Prince William County next week, starting on Tuesday, the 23rd, and then are currently planning the next round of where these CVCs will be in the weeks to come. Next slide. All right, so there was also recent legislation. Sorry, is this still me? I think this still might be me. Yeah, so there's also recent legislation that opens up eligibility to vaccinate. So, we have not really had this issue to date. I think there's a perception that we haven't had enough vaccinators, and that's part of why vaccine hasn't moved so much in communities. That's not generally the case. I mean, really, up until the last couple of weeks, it's been about supply in communities. And then sometimes, there was a stage in late January or early February where just like working out the logistics with partners. So if, for example, if a local government's EMS wanted to be vaccinators, making sure that we had the vaccine management covered, that we knew who the vaccine manager was going to be assigned to a VTRAX number from the CDC, that we had MOAs in place, all of that. But regardless, there's been recent legislation that has really expanded eligibility for vaccinators. There are new classes of healthcare professionals now that are covered under this that include dentists, veterinarians, and different student types. And so, I think perhaps in this surge in April and May, that will help. We continue to drive people through our MRC in the Richmond area, for example. About 70% of the people who help make that Arthur Ashe Center and the Richmond Raceway Center work are Medical Reserve Corps volunteers. And so MRC has been an incredible augmentation to the effort. Next slide. And so here we are, wading into phase 1C with a couple of districts. As I said, I expect more districts to kind of turn that direction next week. And I think the entire state will be there by the second week of April. And that then takes us to opening up to the general population, and April and May are going to be really, really significant output. But I actually think it's totally within the realm of possibilities that we offer a vaccine to everybody who wants one. We're able to get at least a first dose in them by the end of May. What does that mean for our goals, our herd immunity, kind of where we go from there? Our target for herd immunity is around 75% of the adult population getting vaccinated. I think realistically, we will get to somewhere between 60 and 65% by the end of May, which means that the work that's already started now in many communities and will really continue through the summer is trying to get that last 10% and really working through those vaccine hesitant populations and trying to just solve the puzzle about why about 32% of Americans are still refusing to get vaccinated. So a lot of hard work ahead of us to get to herd immunity, but I at least to get to the 65 or so percent who are ready to get vaccinated, we're making really good progress, and we'll get there by the end of May.
Thanks a lot, Danny. I really appreciate that. We just have a couple more slides, and then we'll be able to open up for questions and comments from the board. This slide table just shows you some of the funding that we've been able to utilize to support all of our efforts around testing, containment, community mitigation, communications, and the vaccination campaign. We've been able to use a lot of the CARES relief funds, CRF funds for those things that I just talked about. And once the CRF funds are exhausted, we will be able to use the ELC, which is a grant we get from the CDC funds to replace those. The General Assembly also passed some, not legislation, but in the budget has put in some more CRF funds for our use. And once that budget is signed, we'll have access to those funds as well. Next slide. Many of the grants that we have do not extend beyond fiscal year 21. Some do, like this ELC grant I mentioned, and also grants that we received for vaccination. You can take a look at this at your leisure, but we have a good deal of money available to us that we've been utilizing a lot to really expand capacity for ourselves in carrying out the vaccination campaign and building infrastructure in the health department and working with our partners in the VEST to expand our testing and containment capacity. Doing so will really help us in dealing with the effort that Danny laid out around getting the majority of adults vaccinated by summertime, and also preparing us for the recovery and making sure that public health has the infrastructure that we need to deal with all the health issues that predated the pandemic, and to put us in a position to deal with the next outbreak, and epidemics and pandemics that we will see in the future. I believe that's the last slide. Madam Chair, and with that, we're available for questions and comments from the board.
So I'm going to open it up to all questions from all board members, and I think there's probably a lot of discussion here. But before we do that, to my mind, there's a missing piece of this puzzle here that we haven't talked about this morning, and that is the role of local governments in making this happen. In my health district, a number of local governments, but primarily Hanover County, has donated full-time employees to this effort daily. When just anecdotally, when I went to get my shot, I was put into my parking place by the Hanover County attorney. I want to be clear that a lot of, not in every locality, but in lots of localities, we could not be delivering the doses that we are if there wasn't a significant buy-in and a significant sign-on and commitment of resources from those local governments. We've been a partner in this process, and I really want to make that clear that's happened.
Thank you for that, Madam Chair. It's absolutely true. And the places where we have been the most successful in carrying out the vaccination campaign have been the localities where the local jurisdiction, the health department, healthcare system, pharmacies were all very closely, tightly knit and partnering and working together. So thank you for raising that point. It's very important.
I will be volunteering at a vaccine center all day tomorrow. So it is a regular part of my life now. So, all right. I don't know exactly what order we want to do this in. I understand that lots of people have and comments. And so I have opened up my participants button. And if you could just raise your hand or give me some kind of signal, if you'd like to ask a question or make a comment, we'll get through everybody. Or yell out loud.
Hey, I don't see the option to raise our hands. It doesn't seem like that option is on.
Okay, Alex, can you?
Oh, never mind. Never mind. It just came on for me. Sorry.
Okay. Well, does that mean you want to go first, Patricia?
Oh, sure. Well, mine is very fast. Mine is simply a kudos to Dr. Oliver, to Dr. Avila, and everyone else at VDH. I've started on the Medical Reserve Corps volunteering back in December, and it's been incredibly well organized. So just a big kudos. And I agree with what Danny said, that if you haven't been to a mass vaccination event, go, because the number of people who cry with happiness when I give them the vaccine is lovely. So people are it's like being at an ice cream shop, a humongous ice cream shop. Everyone is so happy.
Thank you, Patricia.
We lost the chair. I assume she'll be back, but I see that Dr. Jang has her hand. Maybe we can go with her next.
Do you want me to start it?
Yeah.
Okay, I want to share my personal experience about the vaccination, and it's been a long journey for me, and so I'm not give up yet. I've been waiting for more than 2 months. In January, when pre-registration started, I signed up right away, and then they switched to the local Department of Health, and so I signed up the form one more time, submitted all the information. I patiently waited, and finally they switched to the centralized systems. And throughout this time, I felt my pre-registration is kind of lost through the crack. And not until last 2 or 3 weeks, I got noted about my pre-registration. I check in. There's no information status about my pre-registration. And during that time, I contact the pharmacy. They're only 60-day screening based on 65 years old. There's no place for me to be eligible because they didn't consider pre-existing condition. That was CVS. And then Walgreens started. And in fact, I stopped by the Walgreens and trying to, get a spot for a vaccine. And they said, well, I have to go online. I'm fine. But now every order appointment site, there's no slots available. And I waited for 2 more months. And I even called the call centers. And all they can tell me is I have to wait. There's no further information they can provide me. And I even called my college, who's the local director. I say, hey, if you have vaccine left, give me a call. I'm not jumping to the line, but give me a call if somebody do not show up. Give me a call. I'm glad to make a trip to any center. I can get a call. I did whatever I could, any of the possibilities. And for 2 months and a half, I felt, yes, 2 months and a half. And I still don't know when I'm going to get the vaccine. And university want me to, they say whether I can put my names on. I say, yes, please do so. So I try any possibility I can. And up to this date, I still don't know what the status of my pre-registration. So many friends of mine in the local area know I serve on state board of health. They contact me. I didn't tell them about my personal experience, but I do. I told them we just had to be patient and wait until I will, we are ready, and I encourage them, to get vaccinated. But I would feel like there's been a frustrating experience for me. Nobody can. I call the local department of health. I call the call centers. I watch on the stuff, and I send all the information I can, and I follow all the the instruction closely. They say I had to they say you misinformation. I sent all the information previously informed. They sent me twice. I even information I sent as possible. And I respond all the information quick as possible. But at this stage, after 2 months and a half, I still in a stage that I feel like all the information I provide is like lost through the crack. And but I continue to encourage people when they come to me to get vaccinated and be patient. But I just want to share my personal experience about my COVID vaccination. I never have something like this before, even when I was waiting for apply for my university application. So thank you for your listening.
Yeah, thanks for sharing that, Dr. Zhang. I mean, I think this has been a really difficult exercise for America. We're not used to waiting for things. We're not used to having to ration care. And the reality of where we've been with this is that we had half of Virginia, 50% of Virginia eligible to be vaccinated, yet only 100,000 new doses a week. And so I think very appropriately, we, along with the rest of the country, had to stratify by risk and had to think about who actually is at highest risk to contract COVID and have serious consequences of COVID. And what that means is that there are certain members of the community like yourself and myself who are going to have to wait. I've not been vaccinated yet, despite being pretty front facing in this effort. I can do a lot of my work remotely. I go to the office 2 or 3 days a week. I'm signed up next week. But all that to say that we are now at a stage where some of the folks who are further down in 1B or in 1C are actually eligible. And so I think you will definitely see that open up over the next couple of weeks. You can go ahead and either check your status through the vaccinate.virginia.gov website, or you can call the state call center and have them check to make sure you're pre-registered appropriately. Sometimes there have been issues where people may have entered the wrong email address or the wrong phone number. I'm not saying that's the case for you, but it does sound like where you are as a professor at an Institute of Higher Education, which is phase 1C, that would likely come in the first week of April or so for most of the state.
No, because I do have pre-existing conditions.
Got it. Okay.
And I did what I already done what you're saying, all of that.
Okay.
And I done everything what I could. And I still have, I checked in the website and there's no information about the status.
Yeah. So I guess, as I said, we're really getting to a point now where the 1B population is getting more and more options, and we should be through the 1B population by the second week of April. And so really at this point, it's just a matter of a couple weeks before you get your invite.
Danny, I want to say too that as somebody who is in local government, and I think you're going to hear this echoed probably from almost everyone on this board, the communication is where we have really needed work. I am delighted. I can see it from my end that the doses are pouring in, and we are putting shots in arms of everybody that we get to. But we had a really difficult communication rollout where people did what they were supposed to do, and then they heard nothing back. That feedback loop did not get closed. And so a lot of people felt, I don't know if I'm registered because there's no feedback loop. And in the beginning, there was no real way to hear that. And even now, what we're seeing is people who registered very early in the process, who didn't get feedback early on, who are seeing other younger people getting vaccinated while they are not. And so I think if there's a takeaway, and I know we are all going to want to have lessons learned here, it's about the communication piece of this. The getting vaccines in arms thing has been a heroic effort and has worked beautifully. The communication has really had problems.
Yeah.
So in my case, it's a communication. That's what I was trying to convey. It's a, I done what I could, and then I'm not the only one. But there's I feel there's no communication to let me know what the status, what's the progression of it, when I register. And that's, concrete. If I know I'm going to get the vaccine, let's say another 3 more weeks, I will wait patiently. No problem at all. And if they tell me if that is going to be in middle of April, then tell me why, then I will wait patiently. That it's about a communication. So, but thank you for letting me share my personal experience.
That's well said and really helpful. And yeah, absolutely. I think you're right, Faye, that we will look back and have 100 things that we'll learn for the next go around. But yeah, I think clearly just the expectation and the uncertainty about when this might happen is something that we need to and will continue to do better at. Thank you guys for naming that.
Right. Catherine, you were next.
Well, I think if most of you have read the report that Lisa and I sent in, we have expressed ourselves in that report. But one of the things that we found people, because we represent consumers from this board, and people will talk to us. They see you anywhere, or they'll call you and ask you, or they'll send you an email or text you and say, what's going on? When am I going to be able to get the vaccine? I don't understand. And then when we don't have any answers for people, they don't understand because we're on the Board of Health. Why don't we have answers? And they see other people that are getting it from different ways. They hearsay. Somebody stops in a drugstore and gets the shot. And so they don't understand why younger people are able to get it, and yet they have family members that are in their 70s and 80s who are yet to get the vaccine. So we have tried to work with these people, and people are patient. Like Anna, people are willing to wait if they know that actually they're on a list and that time is coming to get the vaccine. But when they see all of these other people getting it ahead of them, some people are even driving 2 to 4 hours both ways. Vaccine. Why have we not expanded it? While I believe in government, and but I don't think government is always the answer, whether it's local or state or what. Why have we not expanded this to primary care physicians and to to people in pharmacies like Stacy Swartz? She has that's a small local pharmacy. Sometimes people don't want to go to a big place like Richmond Raceway. They don't want somebody they don't know giving them this vaccine that they don't understand anyway. And so they would much rather go to their doctor. Why can't we allow primary care physicians to give this vaccine?
Yeah, I think you're right. We know that a lot of people don't want to go to these mass sites. And so there have been, from the beginning and along the way, increasing access points in pharmacies and providers. And so as supply increases, we'll see more and more of that. I think at the front end of our response from an epidemiologic perspective, right, really trying to contain the spread of disease, the goal was to get as much vaccine out as quickly as possible, which undeniably is going to happen through mass vaccination. I spent a lot of time with a lot of our provider groups over the course of January and February, helping them understand that we really needed to get it out at high volume. And then as more and more supply came in, we would be able to expand the access points. And the pharmacies have been amazing about that. And now we're starting to see more and more providers get access. So I think all of the things you said are absolutely right. And they are actually happening. And I think particularly private providers will continue to happen. Nobody here thinks that government can do this by themselves. We need every element of our community to get vaccine out.
Dr. Avila, I think you've done a fabulous job, and I appreciate you coming in and helping with this. I really do. I'm glad you're here, but I have not seen that primary care providers have been brought in. They may be given like a few doses to give to some people, and that's gone in a minute. And I have consumers who will contact me and say, we've got 20,000 people that could get it right away with my primary care provider, but they are not allowed access to the vaccine.
Yeah, well, if there are particular providers that are still in the gap, please feel free to send those to me. I'm happy to make sure that they've onboarded appropriately with the CDC and that they're connected with their local health departments. Because I think over the next 2 weeks, we're going to see so much vaccine coming in that we're looking for those channels to get it out through. So
may I address, this is Dr. Pearson. I'm so sorry I cannot see the chat, the raising hand. So when it's appropriate, I have a question about private docs giving the vaccine, if I could.
Yeah, I had a question. I think for what we're hearing from some of the private docs are that they don't have the capacity or the capability for the storage requirements for the initial vaccines. Now, I know that the requirements for Johnson & Johnson are a little different, but I think that also was a barrier for many PCPs being able to distribute the vaccine. In addition, for us, for the Medicaid population that we serve, we have a population that are nursing home eligible. They're not in a nursing home because they have attendants who care for them at home. And, I think that that's a population that as we were trying to vaccinate all of the people in nursing facilities, that they were a little left out. And so we're having a difficult time getting those people vaccinated because many of them are homebound or they cannot, as we've just discussed, go to these large events. And, we're in the kind of in the realm of being health providers, health payers. And as we try to help our members navigate and get them signed up, we're signing them up on the website. But again, this is a very highly vulnerable population, and they too are not hearing back. And so, I think we're trying to work with the health department, with Medicaid, to see can there be specialized clinics for this population, because they are just as susceptible, except being maybe in a congregate setting, as nursing home. They are nursing home eligible, except that they have an aide to come into their home.
Yeah, thanks, Linda. I'll two things that I'll address though. The first is really around private providers. I think you're exactly right. Early on, particularly with Pfizer, most private providers didn't have the ability to do the ultra cold storage. But there was another element. When we were only getting about 100,000 doses a week, what we were being judged by to make sure that we were going to get second doses and get increased allocations from the federal government was, were we using the doses we had? And so what we saw is that when there was a really distributed network, and we were going to a lot of different providers, so many providers were receiving vaccine and may have been putting vaccine in arms. They were not getting it into the state database. They were not entering it appropriately. They weren't accounting for it appropriately. And so when I came into this role January 6th, we were 50th out of 50 states in terms of efficiency. And one of the things we recognized quickly is that we need to channel the vaccine to large scale efforts to make sure it can be efficiently given, while we build up the support centrally to be able to help providers through that. And it's still an issue now when providers come on. Like the process the CDC has laid out for us is far from easy. And I know that has been incredibly frustrating for providers. We now have a whole team of about 12 people who work just with providers to onboard them, to make sure they're storing vaccine appropriately, and to make sure they're getting the data into Viz so that we can keep those second doses coming. But as I said, now we're at a place where supply constraint is no longer an issue, and we are going to lean more and more on providers, not only for capacity, but even for the importance that private providers have unique relationships with their patients. And so for the segment of our population that is vaccine hesitant, that may be on the fence, there's no one better situated than a private provider or their nurse to really help them get off that fence. And so they are clearly a big part of our strategy. They just weren't for a couple of reasons at the beginning, but 6 weeks, 8 weeks in, we're seeing more and more providers come on. And then Linda, to the Medicaid population, we have been working with DMAS for the last 3 weeks to figure out how do we identify this medically fragile population and create vaccination opportunities for them. We have, and then the homebound as well. And so Chetan and the team over at DMAS have been amazing, working with their clinical coordinators for Virginia Premier and the other MCOs, and just calling through their dual eligibles, calling through. And what Chetan told me last week, about 40,000 calls over the last couple of weeks. About a third of those folks have been vaccinated. A third did not want to. And so there's some work there to do around hesitancy. And then a third that were ready to get vaccinated. And so we can either, so we're working kind of 3 parallel paths. One is for folks who are able to get to a mass vaccination site and maybe Medicaid pays their transportation benefit, that they just go ahead and sign up. There's, in many of these locations, there's the ability for those high risk medically fragile to get in within a week or so. 2, that we may want to do smaller events that perhaps a pharmacy or a provider might run, where we get both the patient and their caretaker, both all and their family vaccinated at the same time. And so we're looking at, probably next week we'll have a couple of examples of that where we're doing smaller events. And then the third is really with the homebound. And logistically, that's been a challenge for the entire country because of the way that the vials work, right? When you pop a vial of Moderna, you've got to use those 10 doses within a couple of hours. And so you've got to logistically coordinate. Are there 10 places that I can go to reach those homebound individuals and their households, all so that we're not wasting any doses? And I think we do have a team of folks who are working on the homebound solutions. And I think we'll increasingly have good solutions for that. We've also asked the federal government for single dose packaging, because that'll be a game changer in our ability to be able to get out vaccinated individual and not waste any doses.
Sorry guys, in an effort to keep some semblance of order here, to make this work, I'm trying to do a combination of things. One, call on you in the order that you put your hand up, and second of all, take related questions next to each other. So Linda, was that the extent of your question, or did you have something else?
Nope, that was the extent. Thank you, Dr. Lula.
All right, so I think Holly had a related question and or comment, and after Holly is going to be Stacy, and then I'll see who's next.
Thank you, Faye. I think that it's maybe already been answered in some respect, that perhaps some of the office requirements are dictated by the CDC and not necessarily make sense. For example, we're an OBGYN office, and we early on signed up as willing to give the vaccine. We now find that we have to, at least as we're understanding it, make the vaccine available to anybody, not just to our patients. And that creates difficulty in number of people and in giving it to male patients. There creates issues. We thought that we could then be a site, as Catherine was saying, for our patients who already know us, not for any patient who is in that current category. So as we understand the rules, we then chose not to do the vaccine in our office because it was really very cumbersome when it was a first come, first serve, as opposed to serving our patients. And I wonder if other doctors' offices don't feel the same.
Good question.
Who's going to respond to Holly?
I'm trying to figure out, Holly, I think, yeah, so I heard that more as a statement of why you guys chose not to. I don't know.
Right. Yeah, go ahead.
I don't know all the details of what the CDC was initially requiring, or if that's changed over time. I just put my email address in the chat and would love to have, if you guys are still interested in being a vaccinating provider, I'll reconnect you with Dr. Chris Guy-Magami, who's leading our provider relations core, and just figure out, has that changed? Is there more flexibility, and can we get to that?
Yeah, this was as of last week, so I feel like it's pretty current. And
Okay.
again, there's always possibilities for misunderstandings. But again, I do think that physicians, when they're offering to give the vaccine, that their mindset was, I will give it to patients I know. Patients will show up, all those sorts of things. It's a different thing in your office with patients, people who are your patients, than serving the community. Many of us have volunteered at these other sites and are happy to serve the community. We didn't think of our office setting during office hours as a place to serve the community as much as serving our patients, if you understand that fine
Absolutely.
point of distinction. So I'll reach out to you, but I appreciate your checking it and maybe clarifying us, because we'd love to help in a way that we can be helpful.
Sounds great. Thanks.
Thank you so much. Thank you, Faye, for letting me jump in line. I can't seem to find the hand item.
That's okay. Alex is helping me, and we're going to get through this in some sort of sane order. So I think next is Stacy, and then Gary has had his hand up forever. He'll be right behind.
Okay, Faye, I do have a couple of questions that are not related to this, but I'll wait my time for it. I just wanted to clarify something in comments that several people have made. My pharmacy is actually a provider of the COVID vaccine. We've been giving COVID vaccine since the 26th of January. And it is all the frustrations that people are talking about, we listen to on a daily basis. And we have actually, Holly, what you were talking about with physician private practices, we came into it thinking that we would be able to vaccinate our patient population, but that's not how it has turned out. Because of the priorities of VDH, we get a list of people who we are allowed to vaccinate, which can be remarkably frustrating from a practitioner perspective when you have people who you have known relationships with who qualify as 1B, but you say, I'm sorry, I cannot give it to you because I have to follow the list that is provided to us from my health jurisdiction. But I think the frustration is kind of twofold. Yes, we need more providers. Yes, we need more access. Yes, we need more vaccine. But there is a real concern about capacities of sites. The answer can't be just that we have more pharmacy locations that are giving it, because at some point in time, we have to do our day job too. We can't just stop and the influx of calls from people in the same situation that Anna is doing, where we have no recourse. Yes, we have vaccine, but we are not in a position to give it to people who are not in there, and still do everything that we do on a daily basis.
makes it remarkably challenging. So I think that a dual strategy of just what Danny was talking about expanding local providers who hopefully in the future will be able to vaccinate people that they have a known working relationship with, and mass clinics where they can do things of scale, I think is kind of a key moving forward in it.
Yeah, and I think our long-term sustainable strategy, Stacey, is exactly that. Like, people should go to vaccines at the place to get their vaccine at the places they're used to getting vaccines, right? They should go to pharmacies, they should go to their providers. But there was no way that existing infrastructure could do, 4 million people in a couple of months. And so I think that's why we brought on the FEMA resources. It's why health departments and hospitals and health systems have stood up mass vaccination. Again, epidemiologically, getting as many doses out to the highest risk populations first, and then into the masses after, are what we needed to do to get the disease under control. But this is not the end of COVID, right? I mean, we're going to have adolescents who are ready to get vaccinated in the fall, younger kids who are ready in the spring, likely boosters every year as more and more variants emerge. And so we really have to think long-term about ensuring that our pharmacy footprint and our private provider footprint can actually work that into their workflow and be the long-term answer.
Yeah, and I think too, while it has been in some ways frustrating, it is actually a little bit more easy for me, from my perspective. I don't have to make a determination of who has the most chronic condition, because at least I can say, people with expertise in epidemiology are figuring that out, and I'm just going off of a list that they provide to me, rather than having to judge, well, you're more deserving of a vaccine versus this person, because everybody thinks you have equal determination of, they think that they all should get it and should get it right now.
Okay, thank you. Gary is next, and after that, it's going to be Jim.
Thank you, Faye. I don't have a question, more just a comment and a remark. I've been working through emergency management and EMS in our community, and I agree with you, Faye, that the partnership with local government is essential, and that local government in a number of our communities has really risen to the cause and has partnered and helped get this out. Our EMS vaccinators, I think, I've really been pushing this hard, not only in our region, but across the state, I think are key to this. There's thousands of certified EMS vaccinators in Virginia, and the code just expanded the different types of EMS vaccinators that can be involved. And I know that there's a lot of good work being done with those individuals, whether they're helping the health district with an open or closed pod, or they're helping their health system. I know in our area, we're identifying homebound individuals that are not able to get the vaccine in any other manner, that it's difficult for them to get to a clinic. And we're going to work with the health district to get that vaccine delivered to their house and administered by EMS providers. So, and I know that's going on in other parts of the Commonwealth as well. So that's another valuable resource, and I'm excited that they're going to be able to be part of that. I did want to comment about in our region, working with the Central Shenandoah Health District, and that partnership has been exceptional. Their leadership there and their emergency manager are top notch. They have partnered with the communities, with the health system, and we are getting shots in arms effectively and efficiently. We can always do better. The communication could certainly be better, but overall things are going well. And our local hospital, Augusta Health, I hate to call people out, but I am going to say that, has been stellar in rising to the occasion of partnering with the health district and getting vaccines out. And it's just been, we've done some drive-through pods with the health district and the hospital, and it's just been exceptional. Not to tell my age, but I can remember back to my early days in EMS in the late 1970s when the swine flu was prevalent, and we were doing swine flu vaccines, and we're light years ahead of that. This is going very well compared to that. Again, we have lessons learned. We have ways we can improve, But I've been in our area, I've been very pleased with how things are going. So kudos to the health district for all they've done, to Dr. Cornegie and her group, and to our local hospital and our EMS providers.
Jim, you're next, and then Wendy, if you would go after Jim.
Hi, thanks. To Danny and Norm, we really appreciate the improvement that's taken place over the last 6 weeks or so in the volume of shots being given. I have a couple of observations from early on. The first one is that Danny apparently started on that fateful day, January 6th. Is that the date you said, Danny?
Yes, sir.
I would have hoped that would have been November 6th. And I think that's one of the takeaways. And maybe we won't have a problem with the next big pandemic the way we did this time, but we just didn't get started soon enough. I had been very optimistic after our meeting in December. I thought we really were ready to go. But unfortunately, I don't think we were. And there were bunches of things that I guess some early decisions that were made that were, or it might have been that just the decision to decentralize a lot of things sort of messed things up. I had a lot of anecdotal examples of very aggressive constituents and friends who early on went far afield from their homes to get shots. Wherever they learned things were being offered, and they drive an hour or go someplace else, not their home, and get it, and it worked for them. But that's not the way it was supposed to work, I think. And there were some decisions that really I found strange. Arlington County early on decided they were going to delegate the shot giving, the rollout, to Virginia Hospital Center, wonderful hospital here in Arlington. And the numbers and the volume of production was terrific. And then suddenly it changed. The old rule, if it ain't broke, don't fix it, didn't apply. And then there were some problems when the local health department took back the responsibility and tried to do it themselves. Those sorts of things, I think, with 2020 hindsight, we could have done a better job of getting prepared to avoid those kinds of problems. And we obviously are doing a whole lot better now. The one other observation I have, and it's because I'm here in Northern Virginia and I see the Washington Post every day. Maryland, several months ago, back into 2020, was doing much worse than Virginia, both in terms of hospitalizations and cases and deaths, and that was terrific. I mean, it's a somewhat smaller state, not hugely smaller. Yay, Virginia, we were doing better. That's not the case anymore, and I'm wondering what's going on. Where is the concentration of the cases and deaths that is making Virginia fall behind Maryland substantially, and having that circumstance change over the past, say, 5 months?
Danny or Dr. Oliver?
Yeah, Jim, the last I looked at things, the case incidence in Maryland and in Virginia is about the same now. I haven't looked at compared the death rate or what's happening at long-term care facilities. I haven't dived into a lot of the details on that. So perhaps if offline you could shoot me more specifics on that, and I can address it. I think that we're seeing about the same level of community spread of the virus. We'll see what happens. Maryland has lifted a number of restrictions for indoor stuff that we haven't done yet. And we'll see whether or not that leads to any uptick in their case incidents. But that's what I know about what's going on right now. As far as the vaccination campaign goes, I think we're pretty much in the same boat.
Okay, thanks.
All right, Jim, if you have more, we'll come back to you. And I think, Wendy, you were next.
Thank you. I'm going to try to be brief. It's a little hard. I've had the good fortune of working on several work groups on the COVID testing and the vaccine rollout. I cannot say enough. I cannot sing the praises enough of Dr. Oliver, Dr. Avula, Dr. Forlano. Tammy is on this call. So many people. Of course, there have been problems, but we are moving in the right direction. The thing that amazes me is that people do not seem to appreciate how daunting it is in this massive effort, that this needs to be done safely. Every single dose needs to be tracked and protected. These are precious. Thousands of private practitioner, small practices started jumping up and down. And I too, Catherine, was at the receiving end of people throwing hissy fits. Why isn't my practice getting vaccine? I want to give vaccine to my patient. Well, let me ask you a question. How do you know that that practitioner has a refrigerator that is at the correct temperature for storing the vaccine? People have this vision of somehow a cooler of vaccine is going to be delivered and given out. It doesn't work like that. It has to be, every single dose has to be entered into the VIS system. There is a tracking system. There is an ordering system. What we use throughout this Commonwealth, as was mentioned, will determine further allocation, so tracking is essential. How about handling these vaccines? These are not your typical vaccines. Many vaccines, and lots of people on this board know this, but many don't. You shake it up and you give it, right? You shake it up, draw it up. No, the Pfizer vaccine cannot be shaken. There are a million little nuances. So thousands of practitioners were throwing hissy fits because we weren't sending vaccine. I cannot say enough how carefully this has to be done. In response, VDH has been nothing but transparent. And if you look at the vaccine website, you can push the healthcare provider button and it takes you to an enrollment page that details exactly what needs to be done and why. It's very complicated. Similarly, getting vaccines into arms. We now have thousands of volunteers who will be giving vaccines who have not given vaccines before. And VDH is charged with making sure that is done safely. So I talk about these things because it's been eye-opening for me. And I think our role as a board is to stay the course, support these incredible efforts, help people to be patient. It doesn't help. I do recognize the problems in communication. Bit by bit, VDH has risen to each challenge, and we are moving in the right direction, and I would like to applaud all of you. So thank you for listening.
Okay, I think Lisa is next. If I've missed you, just yell again.
Okay, I had a couple of things. Much of part of it, it's a sort of a two-sided story. One is exactly what Wendy said. Kudos to everyone who has worked so hard. This is just a Herculean task to master. And I know the input from everybody has been enormous and the effort enormous. And when you do finally get a vaccine, even your first, and you see at the Raceway, for example, or wherever, one of these larger vaccination sites, Patricia said it perfectly. It is one of, it brings tears to your eyes because everyone is so happy to be getting this vaccine, so grateful. And everyone administering the vaccines is so kind and so helpful. And it was very efficient the way what I saw was happening. So once you get there, it's great. And I think the direction we're now going in is so markedly improved from the first couple of months, which were fraught with frustration. That was what Catherine and I, as consumer members of the board, were hearing from people all over the state, as well as friends in the street. I think more than anything else, it was a matter of communication. The website was only so helpful, but the biggest problem seemed to be that there was no sort of feedback loop. I would tell people register on your pertinent health district, register on the VDH website, and they would do that, they said, but just feel like they would see people hearing, driving to North Carolina in ice and snow to get a vaccine because they couldn't get it here, or somebody would hear that Kroger was giving them. It was a sense that the really aggressive folks could get out there and somehow find a vaccine while you sort of languished and were forgotten on the website. The pre-registration, and what Anna's frustrations were, because I had those personally myself. I had literally five different appointments set up and signed up for that were canceled. It felt like being stuck in the seventh ring of hell, just this hope and then dashed again. And meanwhile, during all of that time, I personally I never heard anything back from any of the health districts, and you could also not easily check to be sure that you were registered. There seemed to be no, again, this is communication and sort of that feedback loop. As Anna said, I think almost everybody is willing to be patient and understand that their day will come finally, but it is, I think, proved very frustrating from what I was hearing all over the place, that people were, and Jim made this point as well, there seemed to be these backdoor ways to get a vaccine, and the official way was sort of not doing anything. So that to me was a problem. I think the beginning was more a question of just not getting the doses that we need. That's obviously improving enormously now. So again, just observations, and with that said, just cannot thank enough everybody who really was on the front lines of trying to roll this out and make it work. I know it's impossible and everyone complains and so on, but those are my observations.
Stacy's going to be next. I just want to throw out in response to that, Lisa, that sometimes perspective is everything. And I think we all heard about folks who are going to North Carolina. And, I got a call from the governor's office to respond to a local constituent about this North Carolina issue. Someone who had written a quite nasty letter to the governor's office. And the response, the constituent had said, obviously North Carolina is doing a way better job because I got my shot down there. And poor North Carolina, they had a glitch in their system, or a decision glitch, if you will, that meant when you signed up in North Carolina, you didn't have to answer the residency question. So while we were all getting the same number of doses, every person who went to Virginia and got a shot in North Carolina took a shot out of the arm of somebody who lives in North Carolina. And that information, once shared, was very useful for me. And I think we are learning a lot about communication here, and perspective. Stacey, you are next.
So I just had a question for Norman, for Danny. Just to look a little bit more towards the future as we go past 1B and 1C, and we're opening it up to the entire general population. Is what do you think is going to be the role of the health departments? Are they going to step back a little bit from determining or sending who gets what in what order, where private practitioners and pharmacies will have more ability to decide, make their own appointments? Or from a health equity standpoint, are you still going to try to prioritize certain locations? Just if you can share with us kind of what your vision is of what, when hopefully that comes in late April, early May, what that's going to look like.
Yeah, Stacey. I think that as we get into the general population, both the ordering for health systems, private providers, and pharmacies will be more centralized. So right now we're building out this vaccine inventory management system that should roll out to providers in about 2 weeks, where your orders each week will come directly to central office. And there'll still be some coordination, but more and more as vaccine supply increases, that will not be needed as much. The lists, I think we're going to work through the pre-registration lists in the next, I don't know what part of the state you're in, but I would guess in the next 3 weeks or so. And that will allow all providers to kind of open up to any eligible population. So right now, actually, there was just a press release yesterday that everybody who's getting vaccine through the retail pharmacy program, so the chain pharmacies and then the folks who are in that network of independent, what is it, CPSEN? I can't remember the name of it.
CPESN.
Got it. So they are now going to be able to open up to any eligible 1B person in the locality that they serve. So that should give you all more flexibility to really just get vaccine out to other eligible people. And then once you get beyond 1B, the health departments will still do equity focused work, right? Like they will still do the mobile clinics and figure out how do we increase uptake in our vaccine hesitant populations, but everybody else will just be wide open to to be a source for whoever wants to come get vaccinated.
And just one other question, as someone, from my firsthand experience, we are seeing, especially as we are administering first and second doses, and we report them, we obviously report it up to the state. They're still getting communications from pre-registration lists. They're still getting communications from CDC, and it's very confusing because we administer the vaccine and then they're getting things saying it's time for you to schedule your second dose. So it kind of instills in them not confidence that we're doing our job correctly. Is there any kind of discussion from VDH about how to marry their database of pre-registrations versus who has gotten INVIS, and that they know that you can commingle that data so that people aren't getting too many multiple communications?
Yeah, this has been a really messy thing that we're trying to find the fix to. So right now we are kind of crosswalking Viz from the pre-registration system. And that happens every day. The problem is that there's generally a lag for Viz records. And so it can be 2, but as many as 7 days before that record actually makes its way to Viz and then is pulled out of the pre-registration database. The other problem is that a lot of our pre-reg data has to have a first name, last name, and a date of birth to be able to match and deduplicate against Viz. And if we don't have that, then that person's name and email address never gets pulled out, which I know is frustrating for individuals receiving those emails and being like, what the heck am I supposed to do with this? So what we've done over the last couple of weeks, we've really tried to push messaging out saying, please update your entry at thevaccinate.virginia.gov. And the reasoning for that update is so that we have correct first name, last name, date of birth, so that we can deduplicate that in Viz. But it's clearly not there. We got a lot of work to do to try to pull those out. The other thing that's happening is next week, the vaccinate.virginia.gov application will allow you to select, hey, I've already gotten my vaccine. And so that'll be another way we can pull people out.
Perfect. And then one last question, and I promise I'll shut up. The one disinformation that we are fighting in community pharmacy is this notion that there is lots of extra doses at the end of the day to provide to people When if you're actually a good pharmacy, you're planning to make sure that you only do your appointments in sets of 10 so that you don't actually have extra doses at the end of the day. But that being said, as you know, other organizations start to increase in this, and they might have an appointment with me in a week, but they can get it at CVS tomorrow. We are going to start to see people pop off. We certainly has been in the news that there are vaccine hunter groups, lists that people have. Is VDH have a policy on that about whether or not they want providers to participate in something like that? Because I can imagine a future where, especially as supply increases and more people are able to get vaccinated, that I might spend an hour trying to find somebody that I can give a dose to if there's not a centralized system where I know there are people who are waiting to get vaccines that is accurately true about whether or not they were vaccinated or not.
Yeah, I've certainly seen the headlines and articles about that. There's not a policy around that. I'm happy to kind of think through that, and maybe it won't even matter in 2 or 3 weeks because it'll just be so wide open. Let me also say that pharmacists are the absolute best at like managing inventory, knowing how much to thaw. I've been amazed watching you guys like actually figure that down to a T. What we have done from a policy standpoint is require that all providers just have a wait list protocol so that you get to the end of the day, if there have been no shows, that you have a list to work off to make those calls. And so Christy Gray has developed kind of a one page on what those protocols are, and that should get communicated when people sign up, but I know it's embedded in a lot of stuff. So maybe we need to do a better job of pulling that out and bringing providers attention to, hey, here's the wastage protocol, and this is what you need to have put in place. At the mass clinics, it's not a problem because we both have wait lists to work off of, and there's a lot of staff and volunteers that you can turn to and get vaccinated. Obviously, that's a little bit harder for an individual pharmacy or a provider group. You know, my answer here would be, I think it's fine to just work through whatever wait list. If the health department's provided you a wait list, awesome. If not, like, let's use the doses.
Yeah. And just Faye, one last thing, just because you mentioned it, I really do want to echo what some of the other people have said about the coordination of groups from the pharmacy side, and from especially when you just mentioned, Christy, trying to get a bunch of small pharmacies together is really like herding cats. And we're really, this is a huge change in our business model. And I appreciate all the patience and the help that VDH has given to pharmacies to help us prepare to be able to do this type of vaccination on this type of scale, and help us to know all the storage requirements and all the things that Wendy just mentioned, because they are true, they are difficult, and we couldn't have done it without their help.
Yeah, well, thank you. I know Stephanie Weevil, our state pharmacist, loves her independent pharmacies and is super connected to you guys. You've been remarkable partners in this, not just in the stores, like vaccinating out of your locations, but so many independent pharmacies have gone off site and targeted specific events. I mean, you really have been a huge part of our vaccination efforts, so thank you. I saw something in the chat from Wendy just to explain what VIS, I've mentioned that a couple times. VIS is the Virginia Immunization Information System. It's a surveillance system that captures all of the immunization data. We've used it for years. And so if you go and get your tetanus shot or your shingles shot, that ports automatically into VIS so that whatever provider you go to can pull your information. But VIS has also been the database that captures all of our COVID vaccination information, and ultimately is our source of truth, what gets reported publicly on the VDH dashboard, publicly to the CDC. So it's really important, for every provider that we build that linkage to VIS. And early on, one of the things we were seeing over and over was that, for whatever reason, either it was like paper registry or there wasn't a sync between a provider's EMR and VIS, or hospitals were vaccinating a lot of their staff early on, the healthcare worker population. And while their EMRs had been linked to VIS, their electronic medical records had been appropriately linked. Their occupational health platform had not. And so there were tens of thousands of people who had been vaccinated, but that information wasn't being ported over to the state database. So VIS is a really key part of our monitoring and evaluation of the vaccination effort.
Faye, unmute yours. You're muted.
Sorry. I was trying not to get background noise. I think Catherine is next. And then unless I have missed something, I don't have anyone else after that. So if anyone else has something, just throw it in the comments, in the chat.
I would just like to go back a few minutes to the report that Lisa and I stressed over and spent a lot of time thinking about how we wanted to say this, because we know everyone has worked really hard and things have improved tremendously. But let's all face it, when it first started, it was a train wreck and it was chaotic at best. It was changing constantly. People would think that it was going to be happening one way and then it would be moved to another. And all we want to know is, we're not here to say bad things about Dr. Avila or Dr. Norm, or Dr. Oliver. They're all doing a great job. What we want to do is, what is the role of the Board of Health? We just want to know what we can do to improve this. What could we have done? It's wonderful today to hear all this communication from Stacy as to what they're doing, from Wendy, from all of our board members. We didn't have that communication. We didn't know what other members were doing. We were very careful not to overstep our bounds as a member of the board, and to contact everyone in the administration to try to help us with that, to try to help us see what could we have done to make it good from the beginning. Is there anything the board members, we felt totally useless as board members because we felt there was nothing we could do.
Catherine, thank you for your comment. I think that part of the issue going into this was the fact that public health is under-resourced and understaffed in so many ways. We were faced with mounting, so I'll give you one example. Being able to communicate with people has improved through the establishment of the call center, right? That call center costs us about $12 million a month. We had no such call center in place prior to the advent of the vaccination campaign. Can you imagine us going to the GA and asking for $12 million a month to establish a centralized call center and getting the money? I venture that we wouldn't be able to get it. We certainly hadn't had it. The only call center we had was staffed by 12 people who were overwhelmed with 3,000 calls a day. Our current call center has 750 call agents, can handle and has handled 15,000 calls in a day while doing thousands of outbound calls. This is the sort of infrastructure you need if you're planning on vaccinating 6 million people. We were not able to get that infrastructure until months into the vaccination campaign. And that's just one example. I could run down a number of examples of ways in which we have improved in the course of this campaign, but it's only happened once the vaccination campaign got launched. So yes, it was sloppy at the beginning. And we were able to get funding from FEMA. We got more funding through grants from the one of the stimulus bills that came down, allowing us to get monies through CDC and elsewhere to build up our infrastructure. The American Rescue Plan that just passed provides billions for this sort of stuff, and I suspect that we'll be able to utilize a lot of those monies as well to continue to build up. I would say that the sorts of things that Jim and Patricia talked about at our last board meeting is the sort of thing that I think if there are members of the board who want to advocate for really building up the infrastructure of our Department of Health, I more than welcome that. I think that's the sort of thing we need. And now is a really good time to do it because people have seen through the pandemic and the response to the pandemic, the importance of public health. Many of you have just told some stories about how people are feeling once they get the vaccine and so on. They're so proud of what they see and thankful for what they receive, and I think willing to support public health. We see it in things like, the registration or not registration, enrollment in public health schools has jumped something like 25% in the last year. There's a lot of goodwill towards public health, and this would be a time, I think, for board members to advocate for us as, and look on your role of promulgating regulations, which is the primary reason for the board. But I think as appointed members of the state government, I think you can also speak out as advocates for what you see is a real crying need in public health.
I just want to clarify, I'm sorry I got cut off for just a second, but I want to clarify that I strongly believe that we had some communication issues that are being worked out, and that we had those communications issues in a pretty strong way in the beginning that stood in the way of all of us. But I object to the notion that the rollout was a train wreck. The communication is an issue, but the people on the front lines giving those shots, that is an entirely different story. And I do believe that VDH did a magnificent job in getting shots in arms.
Well, they absolutely, as it went on and people began to, but it didn't start out that way. I mean, let's face it, people wanted to get the vaccine. They didn't know where to go. They didn't know what to do. They didn't know how to register. And it was just helter-skelter. They didn't know what to do. The communication was terrible. And I just wish there had been more communication with the board. So we knew what was going on. The only thing we got was what everybody else in the state got. We did not, as board members, know anything else that was going on with these board members, or with Dr. Oliver. We would have been happy to help, or with Dr. Avila. And we're happy whenever anybody else is brought in to make the system better. That's all we wanted, was for it to be better.
Well, I do think one of the things that I talked to Joe Hilpert about yesterday, as we are, Patricia, I'm going to let you go, and then I will, let me finish up this thought real quickly, and then I'm going to let Patricia jump in. One of the things I talked to Joe about yesterday, we certainly have the opportunity here, and I know that VDH already has this in the plan, to look back and see where we think we might improve processes. And I think that is part of the process, is to do the ongoing evaluation of our own work. But I want to make sure that we're clear about differentiating our concerns. Patricia, you want to go, and then if we don't have anything else, we'll take a break at that point.
Well, no, I guess I just wanted to respond to the fact that, as Dr. Oliver pointed out, we as a board did start working on advocating for the support of VDH, and as Jim and I wrote up and others supported, that that was part of the work of the board that we did initiate last year, and I just want to make sure that we all remember that. And Catherine, I hear you that there, you know, we're always a work in progress. And thank you, Faye, for refocusing on the fact that evaluation of processes is an important part of what we do. So, you know, I'm happy that we're having that conversation, but just want to remind us that that is part of what we have been doing as a board, is advocating for more public health funding. So that's all I wanted to say. Thanks.
Norm, Danny, thank you so much. I know that you are extremely busy. Thank you for taking the time to work with us. I also, Norm, thank you for showing up at VCU to talk to them about how this works as well. I hear that my students are quite excited.
It went well. It went well. Thank you all for all your comments and questions. And we're looking forward to working with you and, on the vaccination campaign and other aspects of the response. We'll get this pandemic behind us.
So glad to be with y'all. Take care.
Thanks, Danny. Okay, guys, let's take about a 20-minute break. I've got 11:16 on my clock, so let's say about 25 till we'll come back. Our work for the afternoon is not quite as intense. We'll get back and we'll get to it if that's okay with everybody. Okay. Right.
No, mute.
Just remind everybody to mute while you're on break. All right, folks. Most everybody got.
I'm back.
All right. It is now 11:35, and it is now time for Mr. Helpert to do the regulatory update. You ready for us?
Yes, Madam Chair, members of the board, thank you very much. So you have up on the screen the regulatory action update for today's meeting. We have 30 pending actions under development. You can see there how they fall out in terms of proposed, final, and fast track. There were a series of actions that were recently approved that have an effective date in the near future, but after March 31st. If you move down that front page a little bit to the couple of regulatory actions that were taken by the commissioner on behalf of the board since the December board meeting while the board was not in session. The first was final exempt amendments to our hospice licensure regulations. Last summer during the 2020 special session number 1, there was language put into the Appropriation Act requiring every medical care facility licensed by VDH except for nursing homes to permit a person with a disability who requires assistance to be accompanied by a designated support person during the COVID-19 public health emergency. So this action was approved. These amendments were approved by the commissioner in late January. Previously, I think we previously reported to you that the same type of amendments were made to the hospital licensure regulations. And then the other action that was taken by the commissioner while the board was not in session was dealing with proposed regulations for the certification of doulas. You'll recall this was on the agenda for the December meeting. We presented it to the board. After some discussion, the board directed VDH staff to get back in contact with the key stakeholders involved with this to make sure that there was consensus around language concerning the definitions of a state certified doula. We did that, and in consultation with the chair and also Dr. Kinzer and Dr. Puritz, we did come to consensus with the stakeholders on the language. We then recommended that the commissioner approve those proposed regulations on behalf of the board, which the commissioner did in late January. Go to the next page, please.
The PDF.
Hold on 1 second, Madam Chair.
Let's try reopening it.
There we go. On page 2 of the report, we have 19 periodic reviews in progress, and we are required to review all of our regulations at least once every 4 years. So we have 19 in progress, which is a lot. We are working through those. Next page, please. And on the final page of your report summarizes the executive branch review activity that's been completed since the December 3rd board meeting. And you can see there the work that's been done by the Office of the Attorney General, the Department of Planning and Budget, the Secretary of HHR, and the Governor's Office. The Governor's Office has completed quite a few, approved quite a few regulatory actions since December. So we're happy about that. And then, Madam Chair, there is separately you received a detailed spreadsheet that provides additional information concerning all 30 of the pending regulatory actions. And Madam Chair, happy to answer any questions or respond to any comments.
Any questions for Mr. Hilbert?
So you're muted.
Am I still muted? Okay.
Yes.
This is Jim Schuler. I have a question for Joe.
Hi, Jim.
Yes, sir.
I have a question for Joe.
Okay.
Joe, what specifically was the consensus regarding the doula regulation?
It was that the language that we presented to the board in December was appropriate. So we did not have to make any changes to that.
Thank you.
I think that's a really good, Jim, thanks for asking that question. I think it's a really good opportunity for us to see that sometimes we on the board will have perfectly reasonable questions coming out of our own expertise, and it's fine to pause and ask those questions and get back to how things were started and what the intention was. And if we never make a change, or we do, it comes from the right process of our doing our job and asking the questions. Anything else? Okay, well then it is currently public comment period. Do we have anyone signed up?
Madam Chair, we do not have anyone signed up today.
Okay, well then, and I assume there's no one here who might want to be signed up. Okay. All righty. Then in that case, we can move on. Obviously, I don't think we need another break right now, so we will move on to our regulatory action item. And that is the second one.
Yes, Madam Chair, I'm here.
We are ready when you are.
Madam Chair, I am Rebecca Allen. All right, thank you. Madam Chair, I'm Rebecca Allen, the Senior Policy Analyst for the Office of Licensure and Certification. I am here to present fast-track amendments for 12 VAC 5220, the Virginia Medical Care Facilities Certificate of Public Need Rules and Regulations. The documents pertaining to this regulatory action were previously provided to you and are displayed on the screen if you have any questions. Chapter 1271 of the 2020 Acts of Assembly made extensive revisions to Article 1.1 of Chapter 4 of Title 32.1 of the Code of Virginia, which governs the Certificate of Public Need program in Virginia. The amendments removed the prior statutory cap on COPN application fees and included authority for the State Board of Health to establish a fee schedule for the applications that it receives. This regulatory action creates a fee schedule for the COPN program and revises the fee cap on the applications. Virginia Code Section 32.1-102.2, subsection A, subdivision 5, previously granted the board the authority to establish a fee schedule for COPN applications, but the fees were capped at, quote, the lesser of 1% of the proposed expenditure for the project, or $20,000. This fee cap was created in 1996. These fast-track amendments would create a fee of $70 for registration and a fee of 1% of the estimated capital expenditure for the project, with a minimum fee of $1,000 and a maximum fee of $60,000 for all other projects that would not be eligible for registration. The state fiscal year 2020 budget to administer the COPN program was $981,368. COPN application fee revenue in that same state fiscal year was $1,022,030, a 4.1% margin, or $40,662 over budget. For the next state fiscal year, that would be state fiscal year 2021, the budget includes an additional 2 FTEs for the COPN program to provide support for the production of the State Health Services Plan, which replaces the State Medical Facilities Plan, and to provide community outreach and education on the COPN program. With the inclusion of the 2 new FTEs, the COPN program's budget annual revenue target is now $1,189,849. So therefore, there is not sufficient revenue from the current fee structure to support the COPN program. The annual number of COPN applications cannot be accurately predicted, as it does vary from year to year. In the last 5 years, it has varied from a low of 38 applications to a high of 61 applications. Setting the maximum COPN application fee at $60,000, as is proposed in this regulatory action, would be just $4,751 short of the target revenue in a year with the lowest expected number, 38, of COPN applications, and would exceed the target in a year with an average number, or 46, expected applications. And that it would exceed the target in an average year by $244,743. Item 300 of the state budget provides that any COPN application fees in excess of the amount required to operate the COPN program, less 1 month's operating expenses, has to be provided to regional health planning authorities as supplemental funding, which in a year with an average number of expected applications would result in $145,589 being provided to them. The following changes are being proposed to 12 VAC 5 through 20. In Section 10, definitions, repeal of the definition for application fee. In Section 95, fee schedule, it is a new schedule and creates a fee schedule for the COPN applications and registration applications. Section 105, requirements for registration of the replacement of existing medical equipment. The section would now specify that the registration has to be accompanied by a fee prescribed in the newly created Section 95. Section 110, requirements for registration of certain capital expenditures, specifies that the registration has to be accompanied by the fee prescribed in the newly created Section 95. In Section 180, application forms, it specifies that registration has to be accompanied by the fee prescribed in the newly created Section 95. And Section 355, RFA project application forms, specifies that the registration has to be accompanied by the fee prescribed in the newly created Section 95. Should the board approve these fast track amendments, they will be submitted for executive branch review, which includes review by the Office of the Attorney General, review by the Department of Planning and Budget, review by the Secretary of Health and Human Resources, and review by the Governor's Office. After the completion of executive branch review, the fast track amendments will be published in the Virginia Register of Regulations and on Virginia Regulatory Town Hall for a 30-day public comment period. 15 days after the close of that public comment period, these amendments will become effective unless an objection is received from any member of the applicable standing committees of the House of Delegates or of the Senate, any member of the Joint Commission on Administrative Rules, or 10 or more members of the public. If such an objection is received, this stage will serve as a notice of intended regulatory action, and the standard 3-stage rulemaking process is followed to promulgate these regulations. Madam Chair, I recommend that the board approve the fast track amendments to the Virginia Medical Care Facilities Certificate of Public Need Rules and Regulations.
Thank you, Rebecca. if we could please get a motion on the table and then we can have a discussion. Is there a motion to approve?
Linda
Gary.
Hines, I move to approve.
So we have a motion from Linda Hines. Gary, was that a second from you?
That'll be fine, yes.
Okay, thank you much. So we have a motion and a second. Are there questions and or concerns? Jim Edmondson, I know, had a question to start with. Jim?
Yes, I just want to be absolutely sure that I'm not missing something here. The only issue relating to COPN here is about fees. There's nothing substantive regarding the rules to which the COPN process would have to apply. It's only about fees. Is that correct?
That is correct. It is only about fees.
Thanks.
Madam Chair.
Yes. Dr. Schuler, is that you?
Yes, I would have a question on the maximum fee of $60,000. I think I followed the reasoning, but I'm still not quite sure. It seems like a tremendous increase to me, going from 10 to 20 to $60,000. I listened to the explanation, but if I could be given a little bit more clarification on that, I would appreciate it.
Rebecca, address that.
Yes, Madam Chair. So as I had outlined in my introduction, the original fee cap that we had back in 1996 was, or prior to 96, I should say, was $10,000. And in 1996, the General Assembly raised it to $20,000, and then they didn't touch it for another 24 years. And as with everything in this world, inflation happens, the cost of operations goes up. So despite the fee having not changed, the cost to operate the program, the COPN program, has increased because obviously salary and fringe increases on a yearly basis. And the program that we had back in 1996 actually had more staff than we have today, and it's still, the program is a little bit more expensive. So in setting the new fee, the fee is not $60,000 for everyone. Instead, the fee cap is now $60,000. Not every project that we receive a COPN application on is going to hit that $60,000 cap. Right now with the $20,000 cap that we have currently, 61% of the COPN applications we receive are hitting that cap of $20,000. By moving it from $20,000 to $60,000, only 25% will be hitting that $60,000 cap. Because the fee is based on what the projected capital expenditure is going to be on the project. So for your less expensive projects, the fee is not necessarily going to hit that $60,000. There are going to be some amounts between between $1,000 and $60,000.
Thank you.
Are there any other questions? All right, then, Alex, could you call the roll, please?
Yes, Madam Chair. Mr. Kreitzer?
Yes.
Thank you. Mr. East? Mr. East? I can circle back. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison? Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes, that was a yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Schwartz?
Yes.
Thank you. Ms. Waddell? Ms. Waddell?
She's currently muted.
All right. You may be muted, Ms.
Yes.
Excellent. Thank you. Ms. Whipple?
Yes.
Thank you. And then Mr. East?
I know he's here.
Yeah. I saw him just unmute.
Okay.
Mr. East?
Just put it in the comment.
Yeah.
Chat that audio.
Mr.
Tommy,
East,
can
do you
you
want to
check
enter
this?
your? Yeah. All right. I'm not getting a response, Madam Chair. There are 13 ayes
The motion
and 0.
passes. All right, thank you. So that means the motion passes. Thank you very much. And I will say, if you are having problems with the audio, et cetera, when you're called on, just put your answer in the chat. It'll be easier, I think. All right, thank you. Mr. Hilbert, could you do the legislative update?
Chair, happy to. It's up. We have this up on the screen for you. So this was a session where there was actually the volume of bills was much reduced from what it was in 2020 or in 2019. The legislators agreed to impose some fairly strict bill introduction limits on themselves. So there were quite a few fewer bills, but I do want to share with you a number that did pass that I think you'll find of interest. I've grouped them into a couple of categories that you have up on the screen here: health workforce, environmental health, maternal and child health, data reporting, medical care facilities regulations, and then some other miscellaneous bills that I couldn't fit into any of these categories. So as I'm going along, if you have any questions or comments, please stop me, and I'll do my best to respond. I'll talk about the health workforce items first. And this bill was mentioned a couple times already. This bill was, I think, the very first one to get to the governor this session. It raced through both chambers. And the bill does a number of things, but the key thing that it does is it expands the pool of individuals who are able to volunteer to serve as COVID-19 vaccinators. And one of the key provisions is that if you're someone whose license authorized you to administer vaccinations, if your license lapsed in good standing as far back as 20 years, you are eligible to volunteer under this new program that VDH is required to stand up. One thing I'll mention about this is that this will operate in parallel to our existing Medical Reserve Corps. So a number of the orientation and training requirements for these vaccinators is a bit less and a bit relaxed compared to what it is for the Medical Reserve Corps, but we are in the process of standing up this program. Senate Bill 1436, a similar type bill. It's requiring VDH to establish a directory of eligible healthcare providers who are qualified to serve as a reserve and who may be available to assist in the response to a public health emergency. This is going to require us, this will include people who are supposed to be included in this directory are fourth-year medical students. So we will be working closely with the Commonwealth, the medical schools in Virginia, along with the Department of Health Professions, our own Office of EMS, to put this directory together. Senate Bill 1147, so Virginia, we have a nurse loan repayment program that we administer. What they did here, what the legislature did was they said that certified nurse aides are eligible to receive loan repayment from this program. And in the budget, in the Appropriation Act, the General Assembly appropriated $35,000 for fiscal year 22 to serve as a source of loan repayment awards for certified nurse aides. So we were happy to see this. I do have a few items that I've included here that are actually not bills per se, but they are items from the Appropriation Act. Stephanie Gilliam is going to give you a presentation of the budget. So there's a couple of items, though, that I did want to bring to your attention. Get the screen back up. So in the budget is funding and language to require VDH to establish a behavioral health loan repayment program. And there is $1.6 million in the budget to support this, along with funding for a staff person here at the health department to administer this program. You can see on the screen some of the key provisions of the award size and what the minimum service obligation would be for recipients of this program. Also in the budget was $500,000 in fiscal year 22 for VDH to stand up a nursing preceptor incentive program. So again, we also got funding in the budget for one position, one new position to administer this program and the behavioral health loan repayment program that I just mentioned. So lots of good news, quite a bit of good news this session for health workforce. And I would mention that both this item and the behavioral health loan repayment item were actually approved last year in 2020, were included in the budget. But you might recall that so in 2020, March of 2020, the General Assembly approved the budget, then the pandemic hit, and by April, the governor was forced to rescind a lot of the newly proposed spending. The behavioral health loan repayment program and the nurse preceptor program were two of the items funded last year, but then the funding was unallotted. Now this year, situation's improved, it's been put back into the budget in 2021. One other item in the budget that I wanted to mention to the board is language requiring the health commissioner to develop a task force on doula certification regulations and other related issues. So obviously we already have a jump on this with the action that the board took in December on the doula certification regulations, and we will stand up this task force to keep that issue moving forward. A couple of items in environmental health that I wanted to bring to the board's attention. So Senate Bill 1396 started out as one of VDH's legislative proposals that we submitted to the governor's office. And our legislative proposal did two things. It authorized expanded use of the on-site sewage indemnification fund to provide grants and loans to repair or improve on-site sewage systems. Right now, there are pretty tight restrictions on how that indemnification fund is used. What we're proposing is to greatly expand the purposes for which that fund can be used to assist with improving really low-income property owners in Virginia to help improve or repair their on-site systems, because this is an issue throughout the state where there are many systems that need help. And the other part of the proposal was to authorize the board to amend our sewage handling and disposal regulations to make some amendments that would take into consideration the impact of climate change on these systems, which is really felt through rising water tables and sea level rise. This bill, our legislative proposal, wound up getting packaged into a bill with legislative proposals that came out of the Department of Environmental Quality. They had some of their own proposals relating to wastewater treatment policy. So the administration made the good decision here to combine the work of the two agencies into a single bill, and that bill did pass. So we're very gratified by that. Another item in the budget, there's money in the budget along with 3 positions for the health department to work closely with our schools and childcare facilities around testing plans and test results for water, lead in drinking water. This is a big issue. There's been legislation over the past several years addressing this, and this budget item provides necessary resources for VDH to address what is increasing demand for technical assistance and support from our schools and childcare facilities. A few items concerning maternal and child health. House Bill 2111 directs the Health Commissioner to establish a task force on maternal health data and quality measures. So again, lots of interest in maternal health. There's tremendous stakeholder engagement on this topic. There is felt that there's a need for a task force to really drill down on data issues and how the data informs and illuminates quality. So we are happy to do that. House Bill 1950 directs VDH, and specifically our Office of the Chief Medical Examiner, to convene a work group that would be charged with developing a plan for the establishment of a fetal and infant mortality review team, and to report that plan to the General Assembly by December 1 of 2021. So OCME is already starting to work on pulling that work group together and getting to work on developing that plan. House Bill 2019 is a bill dealing with a particular issue that manifests itself in schools, and this is kids who have an asthma attack in school, or who may be at risk for an asthma attack and may not have the necessary medication either prescribed to them, or maybe it was prescribed and they just don't have it with them that day. So this legislation mandates local school divisions to develop policies for the possession and administration of what's being called undesignated stock albuterol to students. It requires our local health directors, our local health district directors, to provide the school divisions with an order or a standing protocol for this albuterol to be administered in the school setting. And the bill also requires VDH, in conjunction with Department of Education, to develop and implement policies for the administration of stock albuterol in the public schools. So we are starting to work on that with DOE. And then House Bill 1995 establishes the Rare Disease Advisory Council. And you can see on the screen here the key purposes for which that council is being established. The bill tasks VDH with staffing that council. So we will be putting together an implementation plan to help stand up that council. So we look forward to doing that work as well. A couple of bills in terms of data reporting that I wanted to share with you today. So House Bill 2007 pertains to, the intention here is to provide greater transparency to the public concerning prescription drug prices. And this bill requires VDH to collect, compile, and provide information on prescription drug prices from a number of different entities, including health plans, pharmacy benefit managers, wholesale distributors, and manufacturers. The bill requires that these data be provided in aggregate form and in such a way as to prevent the disclosure of any proprietary or confidential information associated with the providers of that data. And the bill requires the Board of Health to promulgate regulations within 280 days of the enactment of this legislation. So we are starting to work as a staff on drafting what will be emergency regulations coupled with a notice of intended regulatory action to bring to the board later this year. The way this will work is the data will be reported to VDH via Virginia Health Information, who is our contractor, our health data reporting contractor that is used for many, many different types of data reporting tasks and functions within state government. So we are working closely with them. We'll be working closely with stakeholders to develop these regulations. There are about half a dozen or so states that have already issued their own regulations on this, so we're taking a look at those as well. So the board will see this later this year. Another data reporting bill was House Bill 1989. And this bill requires VDH to develop and implement a system for sharing information regarding confirmed cases of communicable diseases of public health threat with EMS agencies in real time during a declared public health emergency. So this is a big task to pull this, to develop an IT system that will enable this to be done. The fiscal impact for this, as published by Department of Planning and Budget during the session, was close to $1 million. The Senate wound up amending this bill to say that it will only take effect if and when the CDC approves the use of part of our epidemiology and laboratory capacity grant for this purpose. So we've submitted to the CDC our proposed budget for the ELC grant. This is included in there. We will await word of whether or not the CDC approves the inclusion of this item in the ELC grant. We're required to notify the General Assembly of what the outcome is with the CDC. Another data reporting bill is House Bill 2061. This is dealing with the Virginia Immunization Information System, which you heard Dr. Avula make reference to a few times. And this requires any healthcare provider in Virginia that administers immunizations to report that immunization history and information to the registry. This has not been mandatory for all providers. The proponent of this bill was the pediatricians in Virginia. And the bill did pass, but it does have a delayed effective date of January 1. Couple of bills dealing with regulation of healthcare facilities by the board and by VDH. House Bill 2162 requires every hospital or hospice to allow a person with a disability who requires assistance to be accompanied by a designated support person. That bill passed. 2154, House Bill. This is dealing with the use of what's referred to as an intelligent personal assistant. One of your devices you might get from Google or some other IT vendor. This requires hospitals and nursing homes to allow a patient to access and utilize such a device while receiving inpatient services. Senate Bill 1356 is a bill around visitation, which has been a big issue during the pandemic in a number of respects. And this bill requires hospitals, nursing homes, hospice, and assisted living facilities to allow patients or residents to receive visits from clergy upon request during a declared public health emergency. House Bill 2300 requires each hospital with an emergency department to establish a protocol for that's currently required by us to establish a protocol for treatment of individuals experiencing a substance use related emergency. This bill puts requirements on what needs to be in that protocol. So it's making more specific some requirements for what needs to be in protocols for these types of situations. And the last healthcare facility regulation bill is House Bill 1831, which is actually dealing with home care organizations that we do license. And it requires the Board of Health to promulgate regulations permitting home care organizations to provide supervision of home care attendance by licensed nurses through interactive audio or video technology communications. Madam Chair, just one more quick category of bills before I see if there are any questions or comments. So House Bill 1963, this was another one of our legislative proposals. And this bill is all about promoting greater equity in how local health departments are funded via the cooperative budget. And the cooperative budget is comprised of state general funds, local matching funds, and earned revenue. The local matching fund rates are based on local revenue generation capacity and median household income. There's a maximum of, the maximum local match rate under the cooperative health budget is 45%. That's 45% of the state general fund amount that's given to the locality, and a minimum of 18%. Over the past 50 or 60 years, revenue generation capacity and median household income has greatly changed among localities. But believe it or not, those local matching rates have never been updated since the 1960s. The formula that's run does not use current data. So what this bill does is it directs VDH to assess these local matching rates using current data and report our findings to the governor and the General Assembly each biennium. We estimate that the initial assessment that will be done here will show that the local match rates for slightly more than half of the localities in Virginia will decrease. The others will increase or remain the same. We estimate that the average decrease will be about 10%. The average increase will be about 6%. The governor's budget included $10.2 million in FY22. 1.7 million of that was to hold harmless those localities whose rates would increase, thereby reducing the amount of general fund they would receive, and 8.5 million for those localities whose rates would decrease, thereby entitling them to more general fund through the cooperative budget. The budget provisions were amended by the GA, by the General Assembly, to phase in the increased rates over 3 years. So this bill really, the only other thing I'll say about this was the kind of the genesis for this in terms of an agency legislative proposal was, during the course of the pandemic, around about June, it became kind of clear to both us and to the governor's office that there wasn't a good understanding in the administration of how local health departments were structured, operated, or funded. And that led to the discussions, and that led to this bill. So we're very happy that this bill passed. A couple other bills I'll mention. Senate Bill 1414. In 2018, the General Assembly established the Henrietta Lacks Commission, which is doing a number of good things in Halifax County, Southside Virginia. They're working to establish a medical and cancer research center. This bill simply extends the sunset date on that commission for another 5 years. House Joint Resolution 537 recognizes racism as a public health crisis in Virginia, and it encourages relevant state agencies, including our own Office of Health Equity, to consider steps to address systemic racism and its impact on public health. And Madam Chair, the last bill I wanted to mention today was House Bill 1993. And this directs all state agencies to establish and maintain a comprehensive diversity, equity, and inclusion strategic plan in coordination with the Governor's Director of Diversity, Equity, and Inclusion. Madam Chair, I know I went through a lot of stuff real quickly there. Happy to answer any questions or respond to any comments.
Mr. Hubbard, I just had a quick question. Can you clarify how SB 1436 that you mentioned really early in this presentation, how that's different than the Medical Reserve Corps?
Well, I'm not certain that it really is a lot different.
Okay. Well, the reason I ask is
Yeah, it's definitely going, part of our implementation of this, Dr. Kinzer, is we are going to work closely with the Medical Reserve Corps to make sure that whatever we do here is perfectly aligned with the Medical Reserve Corps, and we're not creating any sort of duplicate infrastructure that doesn't need to be created. That's a great question,
Joe,
Tom.
speak
Right.
to that. May I speak to that? This is Wendy.
Yes. Yes.
So Patricia, I'm on the work group that's working on this. It's been very interesting because the legislation allows volunteers to bypass MRC requirements. And so there is a work group that has been quite remarkable, that has been working hard on creating an alternative way to verify competency with minimum requirements. This is the same group that is overseeing, I don't know if people are aware, but if you go to the VDH vaccine website, there are amazing resources that are now there, including provider education, vaccine clinic resources, best practices. There are newsletters to all vaccinators. There's a lot of effort being made to make sure that this is being done safely. It was quite daunting to be told that we now need to allow, hundreds, if not thousands, of vaccinators to be allowed to vaccinate and to bypass the MRC requirements. So they are working hard on this, and there will be skills checklists, and there will be a way to validate that what they're going to be doing is just vaccinating, as opposed to the MRC volunteers who are allowed to fill a multitude of roles because they are required to know about registration, about monitoring, about all different things. So this will be very focused. So just know that VDH is working hard on this.
Thank you for clarifying.
Thank you, Wendy.
This is Jim. I have a question.
Okay, Jim, hop in.
Well, first a comment. I had my first shot administered by somebody who was in the Medical Reserve Corps. That the woman was a retiree from the health department. She was an administrator. She did just fine. She'd gone through some sort of a training course. I was not aware until that episode that non-medical people could be a part of the Medical Reserve Corps, but it worked just fine. Anyway, my question to Joe is, was there any bill which was considered in this session that dealt directly with making preparations for a future pandemic and putting any requirements on VDH to do so?
Jim, I would say the answer to that is no.
Frankly, that's a bit discouraging.
I would say in terms of that, and I think Faye alluded to this briefly, but we will be doing, as an agency, an after-action review of the pandemic response. And clearly, preparation for the next pandemic will be, I assume, a key objective for doing that after-action review. There are many things that we could have done better, clearly, and so I guess what I'm saying is we don't necessarily, as an agency, we shouldn't have to be told by the General Assembly to do that, and we're doing it on our own.
I fully appreciate that, but what's discouraging about it is that legislators, individually or collectively, don't seem to be very concerned about it, and I think they ought to be. I'm going back to the work that Patricia and I did and that the board considered last summer, looking for things that we might want to have included among bills that would have been submitted during the special session. Maybe we should talk about this at a later point in the agenda, but I don't know how much attention anybody was paying to that, and that's a shame. I just think we've got some policy issues and resource issues that we need to be dealing with regarding public health in the long term. That I'm not getting a sense that we're there yet.
Anything else? Thank you, Jim. Okay, folks. By the way, Jim, we're not gonna let this drop, and I think the idea is to figure out the next step for how we approach inclusion in that process, and we will certainly circle back to that. It's just not a one and done. Our next item on the agenda is our budget update. And Stephanie, are you here? It's always so nice to see you.
I am here. Good afternoon, Madam Chairwoman, members of the board. It's a pleasure to once again be here with you. So I've got an update for you for where we kind of ended up with the General Assembly. Obviously, the governor still can take some actions, but I'm kind of going to walk you through where we are right now with the budget. Next slide. So this table, again, since Virginia operates on a biennial budget, we're always addressing, at least 2 years. So I've got kind of the totality of what's happened the past 2 General Assemblies here. Because again, that first line, our base appropriation, is just what we came into this biennium with. So all those items shaded in blue, that's everything that happened in the 2020 General Assembly session. And then the next 4 lines, you'll see where I've got the governor's introduced and then General Assembly changes twice over, because I've made a distinction between things that are in the governor's introduced budget that will be part of our base budget sort of in perpetuity, versus things that were just done for the pandemic. So those are obviously kind of temporary measures that aren't, going to eventually roll into our base. And another thing I kind of wanted to point out here, you can see our proposed base budget after everything for FY21 is shy of about $800 million. But one thing I want to point out is that doesn't actually reflect a lot of the in-year appropriation increases we had to do. As we got all these federal grants pouring in to help address the pandemic, we did in-year adjustments, which doesn't end up reflected in our base in the actual budget bill. We actually are over $1 billion now in appropriation for FY21. For FY22, you can see we do have some more of it built into our base, but even the $41 million there that was in the introduced governor's budget for non-general fund, that was what we anticipated we would need in base for the COVID ELC grant, that epidemiology laboratory capacity grant, and that was just based on the previous grants we had, and not even this newest $491 million. I say all this just to point out that even though we're at about a $930 million in appropriation in 22, I fully expect that number is going to go up significantly once we do further in-year appropriation increases next year to cover some of those new federal grants. Next slide. So I typically include these kind of pie charts to kind of show history, and I almost didn't include it this time because it's a little unfair. Because again, you've got this massive infusion of federal funds due to the pandemic, and a lot of that is going to be kind of temporary. But one thing that I will highlight is virtually all of our pandemic response is federally funded. Things we had asked for general fund ultimately, is now going to be funded by these newer federal grants that we got that we didn't have at the time we made our proposals. Anyway, we'll move on to the next slide. So I normally don't actually get to meet with you guys like in December as I did to kind of walk you through the things that VDH requested. So I normally only start with what was in the governor's introduced budget and walk you through the GA. So since I already informed you of kind of what we had asked for, I wanted to go through sort of the full update on everything I had mentioned before. So these first ones are again related to the pandemic funding. The first one, we'd asked for about $90 million over the biennium for the mass vaccination effort. Well, as you know, that the federal legislation that passed in December, we got a $77 million vaccination grant out of that. So what the General Assembly has done is basically net off the amount of that federal grant from the total 90 we had asked for, but then backfill the difference with additional CRF. So we're still going to have the 30 million in FY21, but just 12 of it's going to be CRF, and the other 18 is going to be on that new vaccination grant. They were able to give some more CRF because DMAS had some unspent balances that they basically realigned. Similarly, we had two different items for pandemic communications, and they're still giving us the same total amount of resources, but as opposed to it being state general fund, they've now made it CRF in both years. And those amounts are things, you don't actually see them in our section of the budget or budget amendments necessarily, the specific dollar amounts, because the CRF is distributed in the back of the budget bill under a central appropriations section. Next slide. Similarly, again, we had a request for some data modeling contracts, and same thing where they've taken out the general fund, but have instead asked us to move it on to that new ELC grant that we received. We did ask for general fund match for a particular COVID grant that CMS gave us for OLC. That did stand. I mean, again, that's not something they can replace with another fund. We literally matched to leverage the federal funds, so that did stay in place. Next slide. So there were some additional General Assembly related budget amendments that are COVID type items. The first one, it's technically a language only amendment, but it's just directing us to make available a little over $6 million from our new ELC grant to the Department of Behavioral Health and Developmental Services. Sorry, just checking the chat now. CRF is the Coronavirus Relief Fund. That's the $3 billion that the state got to do with what it needed to do. So that's, again, that big pot of money that the state got. The ELC is, again, the Epidemiological Laboratory Capacity Grant. We've gotten several iterations, again, the newest one of which is about $491 million. All told, the combined amount of ELC grants that we've gotten to date for COVID are over $700 million at this point. And MEL, for the record, is maximum employment level. I think that's all our questions. Sorry, I'll try to pay better attention to that. So, again, the first one is just directing us to set aside some money or to provide funding if needed to the testing and surveillance effort at behavioral health. And then the next one is, as Joe mentioned, a IT system for EMS that is, again, dependent upon the CDC approving it being funded out of their grant. And then the last one here is another earmark asking us to provide $34.5 million of that ELC grant to institutions of higher education. Next slide. So going back to things that we had requested, we had asked for some changes to the LARC program to just modify some language to give us additional flexibility. That was included, but the governor did also add another $1 million to the program, so that's great. The next one was just a language only, making some updates to what was written in the budget bill about ADAP and the State Pharmaceutical Assistance Program, and so that was included. And another one that Joe had talked a little bit about is that wastewater infrastructure grant manager position. That one was kind of technically came out of the 2020 session, but was unfunded. But this year we tied it to that legislative proposal. I only say that to point out that normally they would have given us an FTE, but we got the FTE coming out of the 2020 session. And when they took the money, they never took that FTE. So that's not actually a problem. That's, again, the actual position that we would require. Next slide. So one thing that, and to kind of Jim's question is about, preparing us better for future pandemics. We did have in a request, to strengthen our infrastructure for disease surveillance and investigation. We had actually asked for 2 positions for every health department, an epidemiologist and a communicable disease nurse. as well as 5 positions that would have been at our EPI level. And we also asked for some contractor conversions to give some more stability, but ultimately the governor only provided us 26 FTEs, 24 of those for the districts and 2 for Central, but the General Assembly did go and kind of pick up half of the difference between what we had asked for and what the governor provided. So in total, we're going to have 47 FTEs for CHS and 3.5 for EPI. We're not going to be able to do those contractor conversions, but again, we do still have the ability to have the contractors. It's not ideal because, again, we had wanted 2 new positions for every health district, and we're obviously not quite going to have that. Now we're going to have to figure out, how best to deploy the 47 that they've given us. But it is still an investment. I mean, at one point, they had actually, the House had tried to convert this over to that ELC grant, and we made the case, no, this isn't about COVID. This is about, preparing us for future pandemics as well as other issues with healthcare-associated infections and things of that like. So the General Assembly did kind of hear us, and they are, making some amount of investment. So I think that's a step in the right direction. So the next one that we have, we've requested additional money to improve the IT bandwidth in the health districts and some other regional offices, and that was included in the governor's budget, and the General Assembly did not touch it. So that's great news. Next slide. 2 things that we had asked for that neither of them made it into the governor's budget was we had asked for funds for a state overdose fatality review team for the medical examiner's office, and the governor did not include that. We'd also asked for just an increase to our MEL, our maximum employment level, to have some additional FTEs, some of that for contractor conversions and some for some other purposes. Basically, we were indicating, we have the funding, we just don't have the position level, but neither of those were actually included in the governor's budget. Next slide. Another one that didn't make it into the budget, we had asked for the ability to basically save about $1 million of turnover and vacancy that might happen in CHS, the collective of the health districts, any given year, and kind of be able to repurpose it to improve health outcomes in the subsequent year, and that was not included in the governor's budget. As Joe mentioned, there was the update to the match rates for the local health districts that the governor did fund at the $10.2 million level, but the GA has wants us to implement that over 3 years. So they basically removed the hold harmless, thinking that if they phase it in, you don't necessarily need to do that, and then took that $8.5 million and reduced it by 2/3. So obviously we'll get twice that amount for 23 and the full 3 times that amount for 24. And at that point, we'll be able to fully implement that new rate structure. So it's not ideal. It would have been nice to be able to kind of do it all at once, but the fact that it's getting done at all is really great. Next slide. So then VDH had some technical amendments. The first one was just a net sum zero of non-general fund appropriation between programs. And then the second one here is that DSS had reached out to us about giving them back appropriation they had given us for the Healthy Families program. And they weren't going to stop giving us the money for Healthy Families, but they discovered that having given us a specific dollar amount made it difficult to change that on an in-year kind of basis. But for whatever reason, that was not included in the governor's budget, so we retain that appropriation. The next one was DBHDS is transferring $1.3 million of general fund over to us for the purchase of naloxone. They realized that it's just more efficient to have that money in us with our pharmacy capacity. The next one was removing a credit line that the Division of Vital Records got a few years ago and never really needed. That has been removed. And the bottom one here is one I mentioned previously where we got some base appropriation for those new ELC grants. Again, it's not going to be enough, and we're going to have to get some more administratively, again, possibly even more this year and next year, but not a problem. We're set up to do that kind of thing. Next slide. So now we venture into things other people have done. So when the governor's introduced budget came out, there were just a couple of items that VDH didn't actually drive the request, but were included in our section. The first one was additional funding for the Special Olympics Healthy Athlete Program. The governor had added an additional $10,000 for that. The General Assembly did come on top of that and add another $40,000 for a total of $50,000 for that program. and that's in the pass-through section of VDH's budget. And the second one here is just language directing us to support the Virginia Partners in Prayer program. Our Office of Health Equity already provides support to them, so the language amendment really isn't necessary, but it's in there, so that's fine. Next slide. So these are budget amendments that specifically came out of the General Assembly, and these first three are all things that Joe talked about where they're actually restorations of items that had come out of the 2020 session but were subsequently unallotted, the money for that behavioral health program, the nurse preceptor program, and again, some money to fund a position to manage those programs. Next slide. And another restoration we had is the previous 2020 session established the Virginia Sexual and Domestic Violence Prevention Fund. It was supposed to have gotten $750K a year in general fund, but again, that was removed. It hasn't been fully restored. Again, it's only $650 in 22, but it's certainly better than having no funding for this new fund at all. So that's good news. Next slide. So now we get into some of the things that were new coming out of this General Assembly session. And another one Joe had talked about is that new nurse loan repayment program for certified nurse aides. They've included $35,000 for that effort. Then there are two related to EMS. The first one is just adding 30 full-time positions for them that'll be funded through their non-general funds. And a lot of these are going to be in the regional EMS councils, which they adopted a hybrid model that utilized more state FTEs in it in one of their locations, and it's been really successful, so they kind of want to expand that to other locations. But again, using their special funds that they receive. And then there's also a language amendment in there that directs quarterly distribution of the 4 for Life funding to the Association of Volunteer Rescue Squads. So it's just language only about sort of timing of payments. And next slide. So we have the first one here, another one Joe had talked about a bit, is a plan for a fetal and infant mortality review team. Again, the general fund that they put in here is just for that work group to do its work. The expectation is that, we'll come up with what that review team would need to look like and essentially go after the resources during the next General Assembly session to actually fund the review team itself. The next one just clarifies that certain charity care provisions don't apply to nursing facilities. And then there was a House bill related to establishing a rare disease advisory council. They've given us a bit of general fund for that. And then the last one on this slide is adding more funding to the adult sickle cell program. Last year they provided $305,000, and that was not removed because it was tied to legislation. So this will be $500,000 on top of that, so a total of $805,000 for that adult sickle cell program. Next slide. So they did attempt to address the local health department rent increases. According to the language, the amount provided here is to fully restore the I think it was about $75,000 that was the FY21 rent increases general fund share, and then some other targeted increases as well. Another one Joe had talked about is the bill relating to prescription drug price transparency, and they have given us about $394K for that. And then there's the Task Force for Maternal Health and Quality Measures that Joe had also talked about, and we've got about $151K for that effort. And then there was, again, that language only about the certification of doulast program. And developing that task force isn't necessarily new. Really, this language just kind of, makes it plain what we're already kind of actively doing after the doula legislation that came out of the last full GA. Next slide. So there was also $60,000 put in for the study of the PFAS and the PFOS, et cetera, in drinking water. And then another one Joe had mentioned is the additional $250K and 3 FTEs for that lead water testing at both the schools and the daycare facilities, child care. Next slide. And so the last one we have here is a pilot program to study the use of vertically elevated septic systems. It's basically us and the Department of Environmental Quality with the Middle Peninsula Planning District Commission to do this 3-year pilot program. And there are resources provided. They're just provided directly to Middle Peninsula Planning District. So we're just to kind of help partner in the study since VDH and DEQ are involved in the sort of septic and environmental issues. Hang on, I'm just now looking at the questions.
Wendy doesn't like acronyms.
No, I think I addressed the acronym questions earlier, I believe, and I apologize for that. I was looking at Jim's question, and I'm like, if we went back to like that table slide I had, I mean, you can see there are 84 new FTEs that collectively came out of the governor's budget and the various actions in here. Because there are the 50 and a half that are related to that disease surveillance infrastructure. There are the 30 that are for EMS. I think that's it. No, well, there are a couple other bits and pieces here and there because there was a half of an FTE for sickle cell and things like that. So we're not flat on FTEs. I think maybe where the confusion is because VDH had asked for an increase to our MEL. Our specific increase was not included, but there are some other targeted increases that have been included in things.
How do you deal with the 900 odd hires that for I guess contact tracing and the like? They're not permanent, I guess, but are they factored in any way?
Those are contractors, so we don't actually have FTE only relates to full-time equivalent. That's what that acronym stands for. So that doesn't represent wage or contract positions.
Is there any likelihood that at some point we're going to have some people who are not contractors to do that kind of continuing work, especially if there's going to have to be continuing vaccination over the next years because of variants and just getting reluctant people finally to sign up?
Well, so again, the ELC grant that we recently received is good to a point in FY23, and then the vaccination grants are good for even longer. So we have a good amount of federal resources that, you know, we can continue on with the contract labor that we've hired. So we're not in any, you know, for this pandemic anyway, any immediate concern for not being able to fund, you know, the containment or vaccination staff. Does that answer your question?
Yes, thanks.
Okay, are there any other questions for Stephanie? I don't see anything else. Stephanie, thank you as always.
No problem. Thank you very much for having me.
You have a good day. All right.
I did have one more slide. I forgot about it. I'm terrible. No, I forgot about this. I wanted to highlight real quick. This is the table of everything that was given to us in the 2020 session, but unallotted due to COVID. And I just wanted to highlight the items in green are things that have been at least partially or fully restored. And I bring this up because there are a couple of items on this list that are pretty important that I would fully expect VDH may very well try for a budget amendment next session, since we weren't lucky enough to have them restored this time. That's if the Secretary will allow us to do so anyway.
Thank you very much.
Thank you.
All righty. Any questions about that one, anybody? Okay. Well, it looks like the only other thing that we have is the appointment of our nominating committee. I have asked Stacy Schwartz to chair that committee, and on the committee will be Dr. Miller and Dr. Kinzer. And I think that's all, unless there is other business from anyone. Are there any other questions or concerns or things we should be thinking about? Things we want to share with staff before we leave for the day?
Hey, I just wanted to get back to the concerns that I had expressed earlier that you said we certainly weren't finished talking about them. And I'm concerned about resources. Obviously, we've got huge resources related to the immediate vaccination issues. I'm concerned about the inequities associated with administering them. And I recognize that we're trying all kinds of things to make that work. But I'm also just still concerned, as I think we were collectively last summer, that we've got a long-term problem that we've got to try to deal with that demands resources, dealing with outcome inequities and accessibility. And we need some resources for that. We need to figure out how we're going to make a difference in communities of color and in rural communities where the residents are spread out and accessibility is so hard. And I would urge the staff to think about those things even more than they do already, so that we can have a specific recommendation to go to the governor and the General Assembly later this year, just in and anticipating trying to get a better outcome for resource allocations that go beyond just what we get from the feds. And I just think it's terribly important as a matter of equity and common sense for the operation of our public health program here in the Commonwealth.
Jim, what would be, I think, your specific ask here? How do we move this along?
Well,
because we have asked really specifically, and I think while the governor did not address our letter, there certainly has been some funding, but I totally understand your point. And I guess my question is, and Joe, feel free to hop in here. What's next?
Well, I guess I would start by going back to our product, both the interim product and the final product of this letter that we sent as a board last August or September, and think about things that are beyond just response to this pandemic. I think we had a pretty comprehensive set of ideas, and I would like us to go back with the evaluation of the staff by the quality and achievability of some of those thoughts that went through our strainer back in last summer, and just think in terms of long-term effects in Virginia. I think we've done some good thinking about it as a board, and Lord knows the staff has been pushing this stuff that it was achievable in this most recent go round with the budget. But we need more, ever more. I mean, I understand that resources are limited, but we got to be better prepared the next time than we were this time, and that means talking about things like the materials, the supplies that we need, as well as plans for rollouts of when we need additional personnel or pop-up clinics or mobile clinics to reach into areas that are really hard to access. Transportation arrangements for getting people who don't have their own transportation to sites where they can be treated. I mean, they're just they're a host of things, expensive, but I think we got to do them. And I'm not unwilling to keep pressing the point because that's our job as public health policymakers.
It also strikes me that maybe, and Joe, tell me if I'm really off base here, but it strikes me that one of the things that might be true here, did I lose you guys, is about inventorying, about understanding what we have. So, for example, some districts have transportation systems in place. And I don't mean public transportation necessarily, but like there are a number of districts in my region that have transportation available for seniors who can't get to a vaccine center. And if we better understood where the needs are, we may be better able to respond to them. So maybe part of it is the inventory of what we could need. Joe, thoughts?
Madam Chair and members of the board, thank you. So this is a really good discussion. I guess big picture, what I would say is we're already, at least I'm already thinking about the next legislative session. Okay, so we're always doing all we can to look ahead, to get ready for our next opportunity to make requests, which will be this summer. And one of the things I've learned here over the years is you can never start that process too early. I think every year I'm starting it earlier and earlier. That's just the way it is. That's how you get you need to be prepared. You need to do your homework as you put these requests together. So I'm already thinking about how to tee up the next, this upcoming round of where the good idea is going to come from, right? So what I definitely want to do this time is I want to, and I will involve the board intentionally as part of the process that we establish. I'm kind of figuring out right now, starting yesterday, how to do that from a timetable point of view, given when the board meets and all that. But yeah, I mean, we can definitely, when we put together our legislative proposals this year and our budget amendment requests, I would like to think that we will be taking the board's words to heart here in terms of what our targets are, what we're identifying as issues that need to be addressed in some way, and we will for the June meeting, we will have something on the agenda that is intended to share with you our initial thoughts and get your feedback on those.
Thank you. Linda has her hand up. I'm going to let her go next, and then Mary Margaret after that.
Sure, and actually, I just put it in the chat, and I don't even know if this would be appropriate or, but I wonder if we could see if the governor and maybe the Secretary of Health and Human Services would be willing to come to our June meeting to just hear the concerns or recommendations of the board if we had something succinctly, even the document that was prepared earlier in the year to review, and why we feel that, we really wanted to get it on their radar even more so. I mean, we are a board that's appointed by the governor, but I don't know if that's appropriate.
Here, Linda, I think that's a great idea.
Joe,
Madam Chair?
Yes, sir.
Well, we can absolutely, invite and request the governor and or the secretary to address the board in June. And, you know, we can definitely make that request, absolutely.
Okay, then can we just have, by consensus, if we all agree that that's a good idea? And in essence, I think, given that we're on WebEx, the best way to do that is to say, is there anyone who doesn't think that's a good idea? I think we're good. And then I assume you will all send me your ideas for how we may want to present this, and I will work with those and with Joe in order to move that forward. Mary Margaret, you had your hand up.
Yes, I was just thinking that as we look at our public health infrastructure and how underfunded it has been for so long, that in addition to looking at the lessons the pandemic has taught, or the things we need to do to be prepared for a pandemic or another emergency like this, we also need to realize how much we need to work on just basic public health issues. The pandemic showed us how vulnerable people are who had pre-existing conditions. So diabetes and obesity and other things that have been of concern for a long time clearly need more work. And one of the results of not having done as much as we need to do in those areas has been that it left them very vulnerable. So I just, I think overall, the public health infrastructure needs a lot more funding.
Okay. And I think that is exactly the kind of thing that we want to say in a meeting with the governor, that we've become all much more keenly aware of how dire these things are that we already knew, but they are in high relief at this point.
Yeah.
All right. Anybody else? Linda, thank you for a really excellent idea. All right, y'all. This is our last chance. If not, going, gone. We are adjourned. Nice to see you all. I can't wait till we can see each other in person.
Take care.
Bye-bye.
Bye, everybody.
Bye.